Good morning and welcome to the 33rd meeting in 2012 of the Health and Sport Committee. As usual, at this point, can I ask those who are present to switch off any mobile phones, Blackberries or other devices, as they can often interfere with the sound system. The first item on our agenda today is to decide whether to take an item in private at next week's meeting. The item is consideration of an approach to an agreed work on post-traumatic stress disorder. We normally take the approach papers in private. Can I have the committee's agreement that we do so at the further meeting? Thank you. Our agenda item number 2 is of course, the committee's work on access to new medicines. This morning we have 2 roundtable sessions. The first made up of cancer clinicians and the second made up of patient representatives and organisations. I would at this point probably, because of the numbers, it would be easier if people would go around the table and we introduce ourselves at this point before we move to the session.
I'm Richard Casasola. I'm a consultant clinical oncologist in Tayside.
David Torrance, MSP Kirkcaldy constituency.
I'm David Dunlop. I'm clinical lead for SCRN West and clinical director of the Beats and West of Scotland Cancer Centre.
Mark MacDonald, MSP for North East Scotland.
Aileen MacLeod, MSP for South of Scotland.
Patterson, MSP for Clydebank and Mulgai.
Russell Petty, clinical senior lecturer in medical oncology, University of Aberdeen, and consultant medical oncologist in NHS Grampian.
Drew Smith, member for Glasgow, and apologies to you, convener, for being a few minutes late.
I'm Professor Charlie Gould. I'm a medical oncologist in Edinburgh and the South East Scotland Cancer Research Network lead.
Nat Milne, MSP for North East Scotland.
I'm Noelle O'Rourke. I'm a consultant clinical oncologist in Glasgow and I'm the chair of the Beats and West of Scotland Cancer Centre Consultants Committee.
Richard Lyle, MSP for Central Region of Scotland.
I'm Stephen Harram, a consultant clinical oncologist at the Beats and West of Scotland Cancer Centre.
Thank you. Duncan McNeill, MSP for Greenock and Inverclyde and convener of the Health and Sport Committee. Thank you and welcome to you all this morning. We, by the nature of the round table, we try and do our best to allow that discussion between the people on the panel, and we'll genuinely try and do more listening than talking this morning. But if I could kick it off with just a broad, sort of headline here and ask for views on whether the current appraisal system is fit for purpose generally and for orphan medicines and in your case, high-cost cancer medicines in particular. Would anyone like to kick us off? Yes, thank you.
We have a system in Scotland that does give us a very rapid assessment of new drugs. Often for very expensive drugs, that assessment gives a negative response, which as a clinician can make things extremely difficult in terms of dealing face-to-face with patients who are aware of the availability of drugs, and particularly with the availability of the Cancer Drugs Fund in England. There is an inevitable inequality in terms of access to these new drugs. I guess the counter side, I'm not sure that the process is wrong. The absolute cost of some of the newer drugs, when measured in terms of their efficacy and effect in terms of patient survival, it's very difficult to justify those extreme costs, in my opinion, particularly with my sort of clinical lead for Tayside hat on. I do have some worries about the affordability of some of the newer drugs.
Okay, anyone else? Dr. Dingwall.
I mean, I would agree with Richard. I think these individual patient treatment requests that are made for drugs that are not approved by the Scottish Medicines Consortium is made within a framework described in CEL 17 from 2010, which is legislation put in place by the Scottish Government. And the SMC function is also put in place by the Scottish Government. I think that sometimes there is a perception that there is some permissive discretion or compassionate flexibility that the panels can apply to individual cases, and that's certainly in the West of Scotland not the case. we work very carefully and robustly within the framework described within the Chief Executive's letter. So there is no latitude in that other than to make the decision based on the circumstances of the patient being likely to make them more likely to benefit from the treatment itself.
Yes, Professor.
Yes, I would. I think it's important to really back up to some extent what Dr. Dunlop says there, that IPTRs are not synonymous with SMC approval. It's often quoted that patients who can't get drugs because they're not approved by SMC can access them through IPTR processes. It's very, very difficult to get cancer drugs through that process, so these things are not the same. And the benefit of getting SMC approval is that then the funding for these drugs then comes to the department. If we have a drug that's not SMC approved and we want to access it and we put it to our committee in Edinburgh, for example, they are very, very careful not to set a precedent of saying an individual can get that drug, because then they're going to have to find the money for all the individuals that are in a similar setting from their existing budget. And that's why it's a problem. So IPTRs and SMC approval are certainly not the same thing. And so the issue for me is how we can access these drugs for our patients, putting the patient at the forefront of this. And, at the minute, there is a big issue, because although these drugs are expensive, they are being given elsewhere in the developed world, And it's a big issue for these patients who can't get the drugs. It's also, there are other issues connected to that. In Scotland, we're very proud of our history of being able to conduct good clinical trials and being at the forefront of medical research. And so we've been involved in proving that these new drugs are beneficial for cancer patients, and we've been at the forefront of that historically. But now we're moving into an era where we're not being allowed to give the drugs that we prove are beneficial. And that has a knock-on effect for the next generation of clinical trials. Because when the next clinical trials come along, they assume that we can access these drugs through our normal healthcare system as the standard of care. Because all trials compare a new combination of drugs to the standard of care. So these new drugs are now considered the standard of care. Because we can't access them, we are also denying our next generation of patients access to the trials of the next line of drugs. So we're moving a generation behind because of this. And that's why I think we need to look at a way of finding a way of accessing these drugs for patients.
Can I come in there as well? Just to agree with what what Charlie has said, but also to confirm what Dr. Dunlop has said, that in effect we are working within the process that is set down, and where drugs have not been approved by the SMC on the basis of cost effectiveness, then we do not have access to those drugs. And I think the real problem that we have as clinicians is that there is a public perception or misunderstanding that somehow we can access these drugs by using the IPTR process, and that is not the case. And that is why the percentages that are quoted as being successful IPTR applications look promising, because in fact so few IPTR applications are actually made, because as clinicians we know that from the outset we will not have these drugs approved. If they have been turned down by the SMC on the grounds of cost effectiveness, then we will not be able to access those drugs for patients through the IPTR process. And the actual point of trying to fill in IPTR forms, have them rejected, raise patients' hopes, take patients through an appeal process that is unbelievably painful for both themselves and their clinicians, only to be turned down at the end of it, is something that not many consultants will do more than once, because they are so upset and distressed by the process on behalf of their patients. So I think it is really clear that the committee understands that the IPTRs are not a way for us to access drugs, that in England they have the Cancer Drugs Fund whereby they can access drugs which have not been approved by NICE. We do not have anything equivalent in Scotland, and our patients cannot access drugs that have been turned down on the basis of cost effectiveness. And I think we all understand the difficulties and constraints there are within the budgets, but I think it is important to say that these are cost effectiveness judgments that are made by SMC. It's because these drugs are so expensive. It's not because they're not effective. And the bottom line is the reason these drugs have licenses is they are effective, they do work, they have proven benefits in patients, but they are very costly. And the SMC is making the judgment to say that we will not have those drugs, and we are then stuck with that decision. And I think the patients don't understand the process in that they have the expectation that they will be able to access drugs, and they can't, and we can't. And we keep trying, and there isn't a system in place that will enable us to access drugs for those patients. Even when we want to try and select out the patients who have most chance of benefit on the basis of molecular markers, we are in many circumstances not enabled to check the molecular markers to identify the patients who might benefit.
Yes. Dr. Petty, is it? Yeah, just the angle of that.
I mean, I would concur entirely with what's been said about individual patient treatment requests. So just to emphasise that, coming back to your question about fit for purpose, I think that it would not be fair to say that the SMC process is not fit for purpose. I think it is from the point of view of an independent health technology assessment, appraisal of a new drug. And certainly I don't think anyone would question, or few people would question the value of that process in terms of determining cost effectiveness. I think that the important distinction I would make in that regard is the cost versus the value of a drug. And in particular, the value of a drug as perceived by society may not equate in a linear fashion with the absolute cost of the drug. And I think that's something that is a key issue that needs to be addressed. The other point to raise, just picking up on what Charlie said, was with regard to clinical research. I think that this is not a theoretical construct that lack of access to innovative medicines will affect clinical research in Scotland. It is happening. And because as clinicians we're not able to offer the standard of care for comparator arms of trials, and therefore that means that we may not be able to offer those trials to patients, which means that patients may not have access to the latest protocols. It would be universally agreed that clinical trials are of benefit to patients. And there are additional benefits beyond that in terms of research infrastructure, economic benefits, retention of clinicians as well. So I think that it's important to realise that the impact on research is not something that might happen, it is happening.
Yes,
as the other clinician that's not spoken yet, I have navigated through the IPTR process now on a few occasions and have been unsuccessful. I think that the unfortunate situation is when patients come, for example, we didn't discuss the options of biological agents that are available just across the border. A patient spoke to a family member who's a director of public health down south, and then asked for a subsequent meeting with myself, and was really challenging me as to why I hadn't actually discussed these drugs with him, and felt that I had done him a disservice by not explaining to him all the options that were available to him, which puts me in a very invidious position because I'm working in quite a deprived area within the west of Scotland, and I'm basically telling patients that, or could be in a position that I'm having to tell patients that there are more drugs that they're not available to get within the colorectal cancer portfolio than drugs that they can access. And yet, when they went to speak to their MSP about this, the MSP squarely put the responsibility on myself to apply for these drugs through the IPTR process. These drugs are not, I'm not able to access these drugs through the IPTR process because they've been turned down by SMC. So the feedback from their own MSP was that it was my responsibility to access these drugs through the IPTR. I've never been successful in accessing these drugs through the IPTR process. And given the legislation as it's written, I would never be able to access the drugs for this particular patient. So I think that's a big issue. And the other issue is that, to back up the research side, I mean, I've just taken receipt of an NRS fellowship and was at a meeting recently whereby the Health Minister gave us a talk about wanting Scotland to be at the forefront of biotechnology and development. And I'm sitting in the audience knowing full well that actually we're not using a fraction of the drugs that we can use. And the drug companies very much are looking at us now as being quite an inferior health service in Scotland and not being able to offer these drugs to our patients.
I think some of that will be familiar to committee members in terms of the problems and the evidence that we have previously taken, and indeed our engagement with patients groups and patients themselves about what they're being told. But I suppose from that headline, if we accept that the SMC have got a job to do, that's been laid down. There are cost pressures. We have heard that as well. So how do we address many of these issues that we have that have been identified here this morning, and indeed in previous evidence? There is a review taking place. What would we be saying to that review? Because I think there is an opportunity, at least here this morning. I think we have had some contact with the people who are going to be, involved in that review, and we will be submitting the evidence that we have taken to that review for consideration. Whether they take any of that on board, I don't know. But I think there is an opportunity to say, well, how could we make some of this better? Thank you for helping me out here, Professor Gurley.
Everybody respects what SMC do in terms of working out cost effectiveness, and it's obviously a difficult job. But SMC largely responds to requests by drug companies to assess a drug, and NICE really respond to requests by ministers to request a technology, to review a technology or a drug. But it would be, certainly from my point of view, it would be great if we could feel that SMC was actually helping us access these medicines. We all know they're expensive, and we're not wanting to bankrupt the health service, but we think there are good reasons why Scotland should be able to provide at least the most effective of these drugs. And there are ways that could happen. If, for example, SMC weren't so hamstrung by rules, and there's a good example of that recently, where we had a drug that came through that the clinicians in Scotland wanted to use it at half its licensed dose. And that may well have made it cost effective, but SMC were not allowed to assess a non-licensed dose. Now, obviously, being half of the licensed dose, there aren't really safety concerns there, but they were hamstrung. And what we've got to realise is that, the drug companies are not going to change their pricing structure for Scotland because we're not a big enough nation. They have money to make on a global scale. So they're not going to change the pricing structure for Scotland, but there is going to be a change in the way that the drugs are priced south of the border in 2014, whereby there's something going to come in called value-based pricing. So rather than a drug have a specific cost, it depends on what value you're going to get. Now, Scotland in oncology, for example, have just moved towards an electronic prescribing system. And because Scotland's a small nation, there is an opportunity for an organisation, whether it be SMC or whether it be somebody else, to get involved in the negotiating with the drug companies, because the drug companies do come with patient access schemes which cut the cost of drugs. But it would be important that those discussions were in private, because it may be possible for Scotland to get access to drugs without that cost of the drug becoming, becoming public in the outside world, because a lot of the rest of the world use the British price as the price that then applies. And an example of that might be, for example, in breast cancer, the drug Herceptin is, when it's used just after patients have had an operation, then it's much more cost effective than when it's used when the cancers come back. So we could pay one price when we're giving it to the patients after they've had their operation, but when we want to give it to the patients when their cancers come back, the drug company could discount it. And that, the drug companies are, from our discussions with them, they have been amenable to that sort of situation, and that could be applied in Scotland because we've got the electronic capture of all our prescribing. So we need an organisation to sit in the middle, if you see what I mean.
I'll just and I'll bring you in, Nanette, certainly. Dr. Dunlop.
I agree with what Professor Gilley said. I think there's an opportunity to negotiate with the pharmaceutical industry, and there's good examples of that recently with a drug called abiraterone, in which the second attempt to obtain approval by SMC was managed with a more acceptable reduction in the cost through a patient access scheme. I think it's unlikely, though, that a lot of drugs will be made a lot less expensive. So if we choose to revise the way that SMC works, or the process that's post-SMC, the individual patient treatment request access scheme or non-access scheme, and if we revise it to make it more permissive, we're going to have to pay for it. And we're going to have to pay for it by either not doing other things that we do in NHS Scotland, or having some kind of equivalent to the Cancer Drugs Fund, which, if you speak to clinicians south of the border, is far from perfect. In fact, it brings more postcode prescribing than existed before, because each of the different strategic health authorities have different shopping lists influenced by their clinicians. So that may not be the answer, but whatever we come up with, if it is more permissive, we're going to have to pay for it.
Challenge. I mean, I think the SMC make that point. If we weren't tough, we wouldn't be coming back and getting these reductions. I mean, I think, in their evidence, they see their role in that. We're welcomed now by Dr. Tim Cook. We're pleased to have you here. Does anyone else want to come in? And then I'll bring Nanette in first. Yes. Sorry, I can't get there. Dr. Petty, thanks.
Just to briefly pick up on the issues around the SMC, I think certainly there is a situation, coming back to the value of medicines, there is a situation where the SMC, as many people know, can apply modifiers to the cost effectiveness analysis, and I think that's very important, and that shouldn't be removed from the process. However, I would say that one thing that I would be concerned about in that regard is that it hasn't always been entirely transparent, at least to myself as a clinician, how those modifiers have been applied. And so, for instance, it is possible to read SMC appraisals and see drugs which look very similar in terms of their application to patients at the end of life, with similar clinical effectiveness and, in fact, similar cost effectiveness. But there are examples of where drugs have been approved in that setting, and the example of abiraterone in prostate cancer has been already raised. But drugs which have a very similar clinical and cost effectiveness profile, and an example there would be Herceptin, the drug in gastric cancer, have not been approved. So I think that the modifiers are a very important aspect to this, but the difficulty has been that it's not always been transparent how they've been applied, and I think that undermines perceptions of fairness of the process. I mean, everybody understands the need to control costs, but it's important that there is a clear perception that that's done fairly. And I think this relates to what has been said just before about the cost negotiations. That's clearly important, but I just have some slight concerns with regard to the transparency of that process and how it might be perceived.
Yes.
Yeah, I'd reiterate Charlie's point there about national negotiation with the drug companies, and if we can get the drug companies to look at reasonable pricing, but to perhaps give some sense of the scale of the issue in terms of the absolute cost of these drugs. I did a sort of back-of-the-envelope calculation and worked out that if I were to treat 10 patients at current cost, 10 of my melanoma patients with ipilimumab, I would be looking at asking my trust for an uplift of 30% per year in my drug budget to treat just 10 patients. So that's the sort of magnitude of the cost that we're talking about.
Nate.
You really mentioned value-based pricing, and we've obviously had that mentioned several occasions, and I find there seems to be a sort of lack of clarity as to what exactly that is, how that's going to work. Is anyone around this table can give any clarity on that? Because I have to say I'm slightly confused with what it means.
I mean, I sit on an SMC, and we've actually had presentations on value-based pricing from pharmaco-economists from south of the border, and left that meeting completely baffled as to what it was actually, how it was going to be deployed on the ground to deliver what it's supposed to be delivering, which is the follow-on from the current arrangement of having a cancer drugs fund.
I went to an ABPI meeting at which there was an economist from down south, and I was utterly perplexed when I left the meeting. Yes.
Come in. Yes, well, I mean, we could come in, we don't have to follow the English model, there would be an opportunity, to set our own model. That's the great thing about some of the infrastructure and the IT systems that are in place here in Scotland, so you could call it value-based pricing, or you could just say, well, I guess it's similar, it's discounts according to what you're using the drug for. And when you're using it in its most cost-effective situation, you pay the full price. And when you're using it in a less cost-effective situation, the pharma company will cut the price, will give you a discount according to the efficacy that you're going to get. Now, there's no doubt that at the end of the day, this has to be paid for somehow. But, and I'm sure you've had the figures that have been quoted to you to get equivalent access that the Cancer Drugs Fund achieves in England. It would cost about £4 per person in Scotland per year. And I don't know whether you think that's, I mean, it may not be the best example because we all accept that the Cancer Drug Fund has its own limitations. But bearing in mind, you're not only talking about getting access to the best drugs for people in Scotland, you're also talking about maintaining Scotland as a country at the forefront of clinical research. And also, attached to that, the clinical research, along with the clinical research nowadays, comes a lot of science, because these are all new biological agents. And, we're always saying how Scotland is such a good centre for life sciences and biotechnology. It's going to be difficult to maintain that if we're not at the forefront of medical research.
Dr. Cook.
Can I just say something? Someone who's come from the Cancer Drugs Fund to Scotland in the last 6 months, having been a medical oncologist in Essex for 2.5 years, where we had the Cancer Drugs Fund, and I could prescribe any melanoma drug there that, in my clinical opinion, would be in the patient's best interests. And there's an equality here, which I think, I'm speaking as an Englishman working in Scotland and looking after patients in Scotland, there's an equality that, to my mind, as a simple doctor, is unacceptable. That I can't offer my Scottish patients the same medication that I could treat my English patients with. That, as a human being and a doctor, that can't be right. The health economics is far too intellectual for a simple person like myself, but my perception is, coming from somewhere else to Scotland, that this does need to be addressed urgently. The Cancer Drugs Fund is full of imperfections, but patients who've received vemurafenib, who've received ipilimumab, as Richard said, are very, very grateful that the Cancer Drug Fund exists. And that would be extrapolatable to any tumour site, I'm sure, with all its imperfections.
Just say also, to follow on from that point, in colorectal cancer, we've got a drug in the third-line setting which doubles overall survival compared to best supportive care. And it was turned down by a multiple technologies assessment from NICE, which apparently does apply over the border in Scotland. And within the NICE documentation, in the summary, they state they look forward to further BRAF analysis as being a group that perhaps we can drill down and try and find people who will be more responsive to this drug. And despite even providing that evidence that the patient would benefit with the BRAF status and the KRAS status, we were still denied this drug. And this is a drug that doubles from 4 or 5 months to 9 months survival in a group of patients that have no other options. They have no treatment options available to them. And that went to an IPTR, it went to an appeal, and it's been turned down despite every single out of 10 experts who deal with this drug across the board are providing supporting statements. At the appeal, it was turned down. And our own professor of translational medicine, oncology in the Beatson providing supporting documentation also turned down. So the IPTR process is not allowing us to access drugs when patients have no other options. That doubles overall survival.
How do we create another system that would give you a better chance, or give them a better chance of getting access to these new medicines and sustaining our reputation for medical advancement and life sciences? I suppose that's where we are now. I mean, yes.
Raise the bar that the SMC set in terms of value for money for these drugs. I don't think the SMC process is wrong, but if the bar were higher in terms of the cost, that would be the quickest way around it.
Would that be a solution? It's my recollection that bar hasn't been raised since 2001. It's around, what is it, £40,000? But it's went up to £50,000 south of the border. So I don't know whether any of these things make a material and significant difference. Yes.
That is a solution, and just to emphasise again, it's not the SMC process that is a solution. But I think that the route to doing that is to apply have a policy, for want of a better word, to apply the modifiers of the cost effectiveness threshold, in a transparent and understandable process, because as I was saying before, I don't understand it at the moment, how those modifiers have been applied in different cases. And in that way, that might then allow the cost effectiveness threshold to be varied according to the value as assessed by a schema policy defined by particular modifiers. End of life care is obviously would be one of those, and things like that.
Yes, certainly come back in, and Gil, you understand I'm letting...
Sure.
Yeah, but okay.
Often when at SMC meetings, when oncologists, I'm the only oncologist on the SMC, are surrounded by cardiologists and rheumatologists who treat other diseases, they find it very difficult to understand why we would want to use a very expensive drug to allow a patient to live from 75 to 75 and a half. They find that very difficult to understand. We find it very difficult not to understand that because we're sitting in front of the patient having that difficult conversation. But maybe we need to help clinicians have that difficult conversation more often and with more support. Because again, I would reiterate that if we come up with a more permissive version of the post-SMC process, we are going to have to fund it somehow.
I mean, there is a difficult challenge in there, about which is a wider point, of course, in terms of what we do in the health service that may not be given as value if we apply some of the SMC principles to other, procedures, or some of them wouldn't survive it if they were making the comparison that you're dealing with every day of the week. So I don't know, and there are wider issues about how we help people at end of life as well, in terms of support, not just simply drugs or care and support, and helping them make these decisions, which is a wider point, I suppose. I don't know whether anyone wants to take any of that up.
I think we all understand understand the financial constraints that there are. And I don't think any of us have a problem with the need to have a cost-effective analysis and the fact that the SMC needs to exist. I guess the difficult thing for all of us as clinicians working for patients is the perception of inequity and the perception that patients have that somehow they will be able to access drugs that patients in England and elsewhere in Europe can get. And that's not the case. And I guess it is the case that if what we want to do is say we are going to maintain the SMC as it is and we're going to maintain the financial constraints that we have, there needs to be a clear message put out to the public that that is a decision that has been made by the Scottish Government, that they are not choosing to spend money on these drugs and that the status quo will prevail. And I think the worst thing of all is for patients to falsely expect that they are going to get standard of care treatment that is as good as elsewhere when that is not the case.
I'd just like to also say, to get away from the perception that we're somehow some group of hysterical consultants who want all of our drugs, all these expensive drugs. I've put in 2 IPTR forms in a year. So I'm selecting out these patients quite rigorously and only applied for patients who I really felt would benefit from this drug. And I cover a very big practice covering the whole of Clyde, from Paisley, Inverclyde, the Vale of Leven. So this is not an indiscriminate asking for drugs for every single patient. I absolutely accept that we do need to drill down and find out who are going to benefit most from these patients. But if we provide evidence in an IPTR, which NICE have suggested would be a thing that they'd be looking for in the future, and it's still turned down, then we are getting nowhere with getting the access to the most needy of patients for these drugs.
Dr. Petty.
To pick up on what you were saying before about are the same rigorous appraisals applied to all new healthcare interventions, and I think the answer to that is no. And I think should it be, and the answer to that is probably yes. And so an example of that would be new devices, and I think it is recognised that new devices are not appraised to the same level as new drugs, and that's an important issue to address in terms of particularly addressing the issue of the finite amount of resource.
New devices
as in, I'm thinking new hip replacement, new knee replacement, new implant, that kind of thing.
Gil, do you?
No, it was just
still relevant to come in at this point. I'm sorry about that.
Just a point with regards to raising the threshold from 40,000 to 50,000. That seems to me just a simple mathematics. Sorry to put it in that regard, that it's an on cost that we may perhaps not have. The budget is the budget, and there's an element to it. So I just wondered what people thought about that. But perhaps maybe the value-based pricing, as I understand it, that has been talked about down south, which effectively will be overarching, which will cover Scotland, since these decisions on approving drugs are made south of the border. So I'm just wondering how we would interact with that. Does our system really, does it disappear, or can it engage? But people are saying they're unclear themselves in that regard. I just wondered if anyone had any views on that matter.
Anyone have any response? Yes, Professor Gould.
There is certainly a lot of vagueness about how value-based pricing is going to work, and I don't think anybody really knows. My understanding is that the situation will still be different here from what it is south of the border once that comes in. I might be wrong, David might know better, but there has been recent agreement down south between the Department of Health and I think the ABPI that they will use drugs that have been approved in the Cancer Drugs Fund to pilot a sort of value-based pricing scheme. So those are obviously drugs that at the minute are not accessible to us, but once value-based pricing comes in, my understanding is the Cancer Drugs Fund will no longer exist. Now, whether that turns out to be true or not, I don't know. but there'll be a grey area where the drugs that have been approved by the Cancer Drugs Fund will not be subject to value-based pricing. And so what will then happen to those drugs in England once value-based pricing comes in? And my understanding is there's been this agreement where before value-based pricing comes in, they will sort of pilot value-based pricing using those drugs. And, you know, that is something that could be replicated up here.
To effectively bring them into the scheme, is that what you mean?
Well,
when you pilot, they then come into a form of approval. But again, my understanding is that, unless someone knows different, that what's been projected or what's been proposed in England actually overarches Scotland also, and it's how we would interface with that and interact in a different way. I know you would like to, but that's the way I understand it. It's going to be brought forward. Since when it comes to the approval of drugs, certainly that will be the case, as it is just now. But then when it comes to the cost effectiveness of them, that sounds to me as if it's UK wide and not specific just to south of the border, unless somebody knows different.
Yes.
Well, unless you're saying that SMC is going to disappear, then cost effectiveness will still be assessed here.
Well, that's what I don't know.
Because that's where historically we've had this difference, in that cost effectiveness is assessed by NICE down south and SMC here. So unless SMC are going to disappear, then I think my understanding is cost effectiveness is still going to have to be established up here for us to access the drugs. Again, could be wrong. Everybody's very vague about what's going to happen in 2014, but
okay.
There does seem to be a lot of layers. If it comes right down to it, we can't afford them. But why have we got all these layers? Why? I think that's a challenge, isn't it? Why do we have these layers of individual patient treatment requests, etc., if nobody's going to get through it? If it is a cost barrier, it's not about the outcome, as we've heard, because the outcomes can be very good. It's about cost. So why are we pretending that?
That's exactly right.
And unfortunately, patients are being told it's not down to cost, it's down to some other system, and it's not, it's down to cost. And I think we need to be honest with them and tell them that we're funding other things, you're not getting these drugs. Because as clinicians, it's very difficult then to have these conversations with patients. Especially if you don't discuss these drugs and they go away and they find out about them and they come back and they challenge you as to why you A, didn't discuss it with them, and B, why are they not getting it?
Yes, go on.
And I was going to say, in terms of equity of access as well, in the limited experience that I have had of doing IPTRs, because it is such a difficult process, I have seen patients go to appeal panels to try and get the drugs. And one of the very, very difficult things with the appeal panels is, and I know this has been set up with the intention that it's in the patient's interests, is that patients are allowed to attend the appeal panel. I don't think people can even begin to understand how stressful and traumatic that is for an ill patient who's dying of cancer. And in the circumstances in which I was in, I sought to protect my patient from having to go to the appeal panel because I knew how difficult it was going to be. And the patient was turned down for the drug. A similar application was made for the same drug, and a middle-class, younger, articulate patient who was in fact a less good case clinically went to the appeal panel and got the drug. And it makes me think then that what we have is an inequitable process whereby if you're able to go through that process and you're articulate and you're vocal and you have that background, you have more chance of getting the drug at the end of the day than the patient who is perhaps more vulnerable. And that's a very difficult situation for us to be in.
Thanks, Convener. I think the first thing it would be important to point out is that while we're approaching this inquiry, many of us, either through family members or through friends, will have been affected by cancer and seen people who've had cancer. So I think that that's worth getting on the record when we're discussing this, that we're not immune to the issues that we're raising. Nonetheless, we have to look at this from a detached point of view at the same time and look at it from all sorts of angles. And I guess one of the angles I would look at it from is that we could have a different panel, and indeed I think next week we have a different panel of consultants from other backgrounds who will all be advocating for their particular specialism. I guess the question I would have is, how do you strike the appropriate balance where you're not seen to be leaning too heavily in favour of one particular area of medicine, for example, and also how do you then balance that against what is undoubtedly a finite budget resource? And I guess I would throw that open in terms of what is the, is there a balance that can be struck that would allow access to some of these medicines, that would allow for other specialisms and other areas of healthcare who may wish to come forward and say, well, hang on, it's not just about cancer drugs. There's also, other diseases out there that need to be given consideration. And then balancing that against what we operate in terms of the budget that's available for healthcare. So I hear talk of the issue around perhaps raising the threshold, and I'm interested in maybe exploring that further and whether there's any indication of what that would then mean in terms of wider availability of drugs, not just within cancer but within other areas, and then what that further means in terms of potential increased costs and where we may then need to see costs reducing in other areas. So I'm interested in maybe exploring that a bit further.
I think there is a perception that we spend a lot of money on cancer drugs, and I'm sure that we do, but I've seen data that I think was presented to the Parliament that says that we spend about 10 million less on cancer drugs than we spend on statins for across the country. So I think there is a perception that we spend lots of money on cancer drugs. I don't know what's that like relative to the rest of the country, but I think it's being made out that cancer drugs are this big, bad, evil, very expensive thing. And
just to clarify, I don't think I was coming at it from.
I'll give you an opportunity to come back, but I wouldn't want you to interrupt the
no, that's fine. I'm finished. That's fine.
I don't think I was coming at it from the perspective of we spend too much on cancer drugs. It was simply a question around, if we make the changes that have been indicated here, what are the likely impacts across the board, and how do we balance that? So it wasn't a case of we're spending too much on this, we shouldn't spend any more. It was more, if we did take the changes to the threshold, what are then the impacts that follow on from that? It was that kind of question rather than framing it in we're spending too much.
These are not my figures. I read all the submissions that had come to this committee before coming along here today, and admittedly this was a submission from ABPI, but in one of their submissions they had put in the relative costs of prescribing in Scotland across different areas of medicine, and they were saying that for cancer our prescribing costs are 60% of the prescribing costs per capita elsewhere in Europe, whereas for cardiovascular drugs we're running at 90%, and for mental health we're running at 100%. And that would suggest, if that's correct, these are not my figures, but that would suggest that in fact we are underperforming, stroke under-prescribing, stroke coming in cheaper as cancer prescribers here relative to Europe than our cardiovascular and mental health colleagues.
Professor Goodley.
Yeah, I mean, there's been talk about raising the threshold. I'm not sure that's necessarily the answer, to be honest with you. Maybe a slight raise to it, but I would rather see SMC having the ability to talk to clinicians and having the ability to talk to pharma and be much more open and be the vehicle that delivers the drug. So the aim is, we accept this as a good drug, we want to deliver it to patients, we have this top line, let's help us get under it. Don't have these hard rules that prevents them looking at a particular dose of a drug. Let's see how we can get it for people in Scotland. So I think that that may be something that we would be better to look at, changing the sort of structure a bit. And in terms of your budget allocation, if this has to all come from the health budget, then obviously you're weighing up heart transplants and hip replacements against cancer drugs. And as you know, a very, very difficult thing to do. But at some point, there's going to have to be a decision taken about the broader implications of not providing these drugs that we've already mentioned, the effects on our life sciences and our place in the world as leaders in this area. And if we lose that place in the world, it'll be much more expensive for Scotland than just, the cost of the drugs, The global implications of that are far greater. So maybe we need to find some money from somewhere else.
Richard Lyle.
Thank you, Chair. Can I agree with Mark MacDonald? I also have had several friends and close colleagues who have died with cancer, and it is a very touchy subject for us all. Can I come on to a comment by Dr. Tim Cook and comments by others? Can I ask, from your experience, you've worked both in England and in Scotland, is it not the case that in England there are also drugs that we supply in Scotland that they don't supply in England?
Very few in oncology.
Okay.
Very few.
Very few, okay. Can I ask Dr. Stephen Harrow, in regards to your 2 IPTRs that you put in, what would you do differently, or what would you suggest that SMC do differently in order for you to get those 2 passed?
Well, I think there has to be a recognition that the way to get them is not through the IPTR process. That's not what the IPTR process is written to allow me to do, and that's become apparent to me. How we do it differently, how we would access it. I feel that as a clinician, I see hundreds of patients in a month. I'm selecting out patients. I think that my clinical skills should be taken as some value when I'm putting forward a request. And actually, there should be the panel, but they should actually be listening to what I have to say, because I am the patient with the experience of the drug, of the condition. The panel do not have an experience of the drug or of the condition. They may have a vague sense of the drug and the condition, but they're not seeing these patients and they're not prescribing these drugs. And so I think surely, as a treating clinician who you have trained in the NHS Scottish system, coming to you, okay, if I came and I gave an IPTR every single day, then you could say, well, this guy's clearly, not playing by the rules. He's obviously, over-expecting what we can deliver, but I'm not doing that. I've come with selected patients who I think would benefit from these drugs, and actually have proven and actually have evidence to say that they would benefit more than the population that were reviewed by the NICE MTA, but despite that, they was still turned down. And I'm still going through the process, and this has been going on for 6 months. Partly there's been delays on both sides of the fence. This is a process that's been going on for 6 months. So it's not a timely process, and it is very distressing for the patient. To pick up a point on Noel's, it was the husband that came to the appeal and put forward very simple statements about his wife and their thanks for what they've had. But then afterwards, he's in tears. I then got to break it to the wife, who's in tears. And yeah, I can do that. I'm a skilled clinician. I can do that. I'm a compassionate person. I can do that. But my anguish is the fact that actually I thought there was a process there that allowed me to go through, and if I put a good case, I would then get this drug. And there is not a process that allows me to do that. The process is stacked against me completely. I'm one lone consultant putting in an IPTR request. There is a machine behind that trying to make sure that I do not get that drug. That is how it feels to me as a clinician going through the service. In the appeal that I sat at, there was representatives from pharmacy who had been reviewing things in the background so that they could put together all the evidence. I'm on my own doing a busy clinical job. I asked if another consultant could come along to the IPTR appeal, and I was said no, that there wasn't allowed to have any other representation, but yet the management structure are allowed to have additional support to try and argue against me getting that drug. It wasn't a conversation as, can we get this drug for this patient? Is it the right patient to give this drug? It was like trying to make sure that I did not get past that point.
So, in regards to, if you allow me, Convener, in regards to that, would you suggest that basically, I agree with the point of maybe the bar being raised, but would it be a case that maybe there should be a situation where clinicians are allowed by SMC to make a case, which you say you've only had 2 in a year? So should there be maybe a figure set to allow those for a clinician, say, to submit that they know that a possibility of getting passed?
Well, I think it should go to an independent panel.
Yeah.
With all due respect, I don't think the person who is holding the budget necessarily should be the sole person to decide whether or not that patient gets access to that drug, because there is a conflict of interest, in my opinion, there. You can't say, to look at the case and also be the one trying to keep your costs down. I think that's a very difficult and invidious situation to be placed in. So it should be an independent process, in my opinion.
Thank you.
Yes, Nanette.
Can I ask, in relation to what you're saying, is the situation fairly uniform across health boards, or is there a variety of process? And is IPTR working the same way right across the country? And
Yes.
I mean, I can only speak for the west of Scotland, but the west of Scotland process is completely confluent with CL17, which is the legislation. I think, we, and I convene many of these panels and chair them and coordinate them. I think I sympathise with the clinicians' position to a degree. However, we have to reflect on the fact that there must be some scrutiny. There must be some common sense applied to these drugs, because otherwise we wouldn't need SMC, we would just ask Dr. Harrow who should get the drugs. And that's not a situation that we can actually accept when we have the governance responsibility to deliver the health service. Because if we just allowed new developments and new technologies to be implemented and deployed without any scrutiny as to their clinical and cost effectiveness, the NHS in Scotland would soon be in even more financial trouble than it is now. So there has to be some scrutiny. It may not be right. So what's there at the moment might not be perfect. But if we're going to come up with a different version of that scrutiny, then I think it has to be less complicated. I agree with that. But it has to be fit for purpose in order to apply the scrutiny.
From a layperson's point of view, just listening to this over the last months, from private sessions to public sessions, there seems to be quite a lot of scrutiny. All sorts of layers. You've got NICE, you've got European stuff, you've got SMC, and you go through all that, and the licensing process, and and we still, have then got all the boards to go through, and then, another level, you've got the individual patient treatment requests. There looks like a lot of stuff in there that from. Well, that's a question I'm posing. Is that the issue? For a layperson, it seems that there's a mountain of stuff that you've got to go through there. Why does it need to be so complicated? If they're all doing a good job, and we've got confidence in NICE, we've got confidence in the SMC, we've got confidence in this process, that process, why do we continually question the same process again and again and again? From a layperson's point of view, it seems confusing. And I know from, as an elected representative, representing people who have actually went through that process, it's very difficult, bureaucratic, and for those people. Yes.
It's useful to hear about the IPTRs because it shows you the stress that the clinicians and the patients are under. But I could simplify it a wee bit by saying that the IPTRs are not the answer for all of this, because they are not a way of accessing these drugs. They're for people who have exceptional cases, and it's extremely difficult for a clinician to demonstrate exceptionality. So they are not the answer. The difficulty is at the SMC level. And you've just said how it's difficult for a layperson to understand why, why this is so difficult. The difficulty is because these drugs are effective in cancer, but they're very expensive. And the value of getting SMC approval is that for the individual health board, if there's SMC approval, the cost of those drugs is paid. If there's no SMC approval, they have to find it from elsewhere in their budget. And so you can make it a lot more simple by just thinking, how can we make SMC, how can we allow SMC to improve the delivery? Because IPTRs are not the answer.
It's your challenge, it's cost, isn't it? They've got to be paid for. Everybody's agreed this is a cost issue.
Absolutely, but it will be if you come up with a system that is more permissive, so if you raise the bar, or if you come up with some other way of assessing the metrics before you approve the drug, then we're going to have to find a way of funding that for the right patients to get the right drugs at the right time. And I think there's a lot of opinion and emotion in the room that is confirming that that's a very difficult thing to do with patients who you as a clinician know might benefit from the treatment. There's a good chance they'll benefit from the treatment. But SMC has determined that that benefit does not equate to being cost effective. And that's the difficulty. But I would agree that the process that occurs post-SMC is very complicated and very difficult to administer, I would also say.
Aileen, and then Gil.
Thanks very much, Convener. Just a kind of related point, we were talking about the kind of complexity and the bureaucracy of the IPTR process itself. But I mean, do you think that there are kind of problems with the whole transparency of the process, as well as consistency across the boards? And if you do, how do you think we can get greater transparency into the process, and also try and get greater consistency across the health boards themselves?
Any takers?
There is consistency because for the very expensive drugs, they all say no. So IPTRs are not really the answer. Now, unfortunately, the situation is that if somebody writes to their MSP and says, I've got this cancer and this drug, I've been told by my oncologist this drug might help me, but we can't fund it, then they go to their MSP. And we have heard that, that there is a process whereby patients can apply for access to these drugs. But, for the new, very effective drugs, I think it's fair to say that the rate of approval is single-digit %. So it really is, it's not at that level that the problem is. That's what we hear about, because these are the cases that get into the papers and things like that. But, it's a bigger problem.
So I was just going to agree with what's already been said in terms of the consistency is unfortunately a negative consistency. But one thing I think it comes down to cost. I think we agree. We seem to have consensus in that regard, and I think that one of the issues is that there is some discordance between what patients would see. It's not cost, it's value. It comes back down to value again, and we appreciate the difficulty with value-based pricing, but I think it is the key issue because I think there's a discord between what the patients might see as value for money, and this would be my perception as an oncologist speaking to patients about this, and we've heard lots of personal experiences regarding that today. So there's a discord between what patients see as value for money and perhaps what the rules of the SMC allow them to say is value for money. And this is why I do think that there is potentially a case for raising the threshold, or perhaps having a tariff of thresholds for different clinical indications. That might be too complicated, but I think that this discord between perceived value according to the rules of the SMC and perceived value according to cancer patients is at the heart of it.
Gil, and then Drew Smith.
I think we all find this a very, very difficult subject, because I think we've all got experience in some way. I wouldn't like to be in the shoes of the folk around this table, to be quite honest. Very difficult. However, what I would say is that for somebody like me, and I hear you can get the drug here, but you can't get it there, but it's not actually the same model that we're talking about. I would need to know exactly what we're doing in preference to drugs. How much money is being spent in place A as against place B, and to try and preventative medicine, or catching cancer or any other illness very early on. Is there more money going in at that end? What this inquires about drugs, I find it very difficult, because I don't think it's possible to come to a solution with one part of an equation. I would need to know what the whole travel is for an individual. Now, unfortunately, the very difficult situation that you find yourself in, you're dealing with people. So my kind of simple bit is to try and get my head around, and I would really like to solve the problem. If I decide that my vote would be to say yes to very expensive drugs, and I'm going to accept it's for a limited number of people, how many people do it affect where I need to take the money away from? And it may well be cancer sufferers. It's that bit that's kind of missing for me, that we've got experts in here talking about one element of the treatment, the drugs element. I would maybe perhaps like to hear some of the things that are happening before we get to that stage. A bit of a challenge, isn't it?
No takers. A challenge to us. I mean, as a parliament, we all agreed to vote through free prescriptions.
That's what we wrestle with.
We didn't. You know, we weren't making that calculation there. I suppose it's that starting point that we're at. Do we, hang tough on these issues and what's available at this point, but make it easy at other points? I think you're right, Gil, that making a point that this is not just one issue. This is an issue for the NHS in Scotland about what we're doing and whether we're measuring the outcomes and the value of all that we're doing, and we maybe get to better decisions, but it's a big challenge. Dr. Cook.
Yeah, can I just emphasise what Charlie said earlier, that there's a danger if these drugs are not available in Scotland, that it will compromise and undermine our status as a Premier League, an absolute Premier League biomedical research country. I mean, in Dundee, the town depends on it, is my impression in my first year there. And you can say Edinburgh, Glasgow, Aberdeen, Dundee, world-class biomedical research, world-class clinicians, Premier League scientists. We haven't seen it yet, but it will come, in my opinion. If these drugs are blanket unavailable, then we will lose our cutting edge. We'll lose our status. That would be a tragedy. It's taken a very long time to build up, and Scotland is correctly and rightly regarded as absolutely world-class, in especially cancer research.
The impression that the First Minister wrote to a number of pharmaceutical companies asking them to invest in Scotland in biotechnologies. And as I said at the NRS meeting a few weeks ago, the Health Minister said that Scotland should be at the forefront of this developing market. This is where the money was. This is what we need to be getting into. And we are not yet providing the backbone, the basic control arm that all of these new studies could be trialled, these new drugs could be trialled against. And that is known, and that is now known across the border. It's now known to, I did a fellowship in Vancouver, in Canada. They know that we are not even providing the basic drugs that other centres are deciding as their controls before you start looking at new technologies and new drugs. And we are going to lose out on being at the forefront of this.
I suppose it's been mentioned. I think someone said earlier that it's happening now. You're suggesting it will happen in the future. Well, what sort of timelines are we? Who are we losing out to? Is there consensus around the table that this is?
Good trial in melanoma coming up next year. Without going into the technicalities, the control arm, to echo Dr. Harrow's point, is with ipilimumab, the drug that Richard referred to, which is ludicrously expensive. But nonetheless, the control arm of a MET kinase inhibitor study, which is the next generation, again, of melanoma drugs, requires the control arm to have ipilimumab. And if your hospital can't provide ipilimumab, you can't have the trial, which deprives Scottish patients of potentially having the next generation MET kinase inhibitor, which, as I say, is a third-generation targeted therapy in melanoma, an awesome drug. We won't be able to offer that trial. So there's an absolutely exemplary point of what Dr. Harrow just said.
Dr. Petty and then Professor Good.
Me that said it's happening now. So my practice is in esophageal and gastric cancer, where the standard of care in many countries would be considered the addition of the drug Herceptin trastuzumab to chemotherapy that's not reimbursed in NHS Scotland. So there are trials that I have not been able to participate in and not been able to offer my patients as a consequence of that. Just to pick up on the point as well, is I think, you know, once it's gone, once the research expertise is gone, I think it's really hard to get back, because it's kind of self-fulfilling prophecy. So, for example, just to give you one example of that, if we don't, the trials that will go ahead without us, and the control arms will be the standard of care. And so when it will be then difficult to go to the SMC because the evidence they have will be a standard of care that is not the standard of care within Scotland. So how can we assess the comparative cost effectiveness under that situation? And that just shows you, that's just one example. There are many others that we could talk about where, you know, once we start to fall back, it will self-perpetuate itself in terms of a negative impact on clinical research, life sciences, the economy of the country, patient, you know, it just goes on and on.
So, what I treat is ovarian cancer, and we're in the scenario now where bevacizumab is a drug that's given to first-line patients in most of the developed world, and it was recently turned down by SMC. And so now new trials are coming on my desk with bevacizumab as the standard arm, and we won't be able to participate. Not only that, it's worth remembering that in an NHS structure where cost is important, sometimes trials deliver cost savings because the companies that come along with these new drugs will provide some of the drugs. And, you know, so because we can't provide the control arm, because we're going to lose our reputation for clinical trials, then, you know, the opportunity to save on those trials and also other trials, which obviously, because the control arm contains what is standard of care elsewhere and is expensive. You know, some trials are cost saving, some trials cost a bit, but, you know, the overall net loss will be the loss of access to these new drugs, which, you know, historically patients on clinical trials do a lot better.
I think another point would also be, you know, we're going to get no net influx of experienced consultants who want to progress healthcare in a hospital in Scotland, because people down just across the border, down in London, will be having access to these drugs, and they know if they come up to Scotland, they're not going to have access to these drugs. And as a young researcher, you know, if this continues, I would see myself moving into another site to gain more experience, because we're now in a situation that I've had no experience of using bevacizumab, despite it being the standard of care across the border and in other countries around Europe and abroad, and limited experience of using cetuximab, not to mention the other drugs that are out there that we haven't even touched on yet.
So, I mean, given that it's pressing, it's coming, it's happening, and what sort of dialogue has taken place with the Scottish Government on these serious concerns? Are they concerns that are accepted by everyone? Is there a contrary view here today? If not, then how, you know, if there is a consensus about this real and pressing issue, then what sort of dialogue? I mean, they're not a remote government. You know, what sort of dialogue is taking place?
I don't know the answer to that, but I certainly think that, you know, this is the first time I've ever been invited to something, and it's really quite refreshing as an oncologist who's working at the coalface to come and actually put your view across. So I have to say thanks very much for this opportunity. But I suspect that it's the same people who get invited to the same meetings who probably say the same situation, rather than the people who are actually starting off and are at the coalface. Because as you get further up, you start seeing less patients, and you're less involved with patients at the coalface.
Yeah. View there. I should point out that in Scotland at the moment, of all the cancer centres, they are all at least one consultant clinical oncologist short of being curate. I interviewed in both Edinburgh and Glasgow recently. In Edinburgh we didn't appoint, in Glasgow we made, I think it was one appointment to 2 jobs that had been advertised. So we're struggling numbers-wise in terms of recruitment to Scotland as things stand. And if this whole issue does make that worse, then I think we're going to be in trouble.
You can't recruit, or you've decided not, you can't recruit because of this?
I don't think it's just this. I think there are a lot of other factors involved.
Can't. Drew Smith.
I was going to ask some questions around some of that, so I think that's been useful. Just on another point, that it goes back to kind of a principle that we talked about earlier on. I think Dr. Dunlop and Dr. Harrow both mentioned it around, is the balance right of where you're making a case for a particular drug, that you are making it with people who understand what you're doing, in terms of this issue about the need for to have a system that deals with the generalities but also deals with the specialities. Should we simply, as a principle, be moving towards a system that says, well, oncologists should be making a case to other oncologists for oncology drugs? Is that possible or desirable? Or
and my answer would be that there has to be some objective arbitration about how we use limited funds for the whole of the NHS in Scotland. There has to be some objective review, because if we just accept that the individuals with the passion and the enthusiasm for all these new drugs and new health technologies make the funding decisions to use these drugs, we will face some very serious challenges. That's not to say that the right patients should have access at the right time with their diagnosis of cancer, but it does mean that the big decisions around funding for expensive drugs has to be part of a discussion involving a wider medical informed community.
Yeah, you know, I accept absolutely what Dr. Dunlop says. In my experience, and this is colorectal cancer patients, I submitted late evidence to an appeal panel, and the appeal panel felt that they couldn't understand the complexity of the argument. They didn't understand the mutation discussion that I was trying to have with them. And so that gets sent back to directorate level and asked for independent specialists to advise. Now, the CEL document and also GG&C's IPTR process is peppered with phrases like, you know, you typically should include a specialist in the field. Well, I don't know what typically means, because any IPTR process that I've been in, there hasn't been a specialist in colorectal cancer. So, but you can get around that by saying, well, the document only says typically should include. But when you're dealing with really complex issues that I find difficult to try and digest and assimilate and put forward in a coherent fashion, and to spend all of that time to do that, to then go to an appeal where people don't understand it, to then go back to directorate level despite having expert documentation to say that yes, what I'd said, the studies were robust, they were very well conducted, and they supported the premise of my argument, to then have it still turned down. It's very, very galling. And at that appeal, okay, the panel maybe are not experts in all of this, but I had documentation from 10 specialists around the country, all who agreed with the principle that were set out in the documentation that you guys have written, that says they should do better than the population and confer and are different to the population that were already studied. They concurred with my argument, yet that still carried no weight. I'm at a loss to work out how else I navigate through that system.
Should we be spending our time in this examining whether or not there are improvements to this system that can be made to say, well, actually, if you say at the strategic level, typically you should have a specialist there, but in practice those specialists are not being there. You know, there seems to be changes that could be made around that system that makes that fairer, or at least makes the practice more similar to what we say the practice should be. But actually, does that really then not change anything? Because the bottom line here is cost, and regardless of who you get around the table, you're going to get the same answer. So, you know, our rationale of why we're making cost decisions might be, well, maybe they didn't understand it or the specialists weren't there. But actually, it wouldn't have mattered whether we had the specialists there or not, because the driving agenda here is to keep costs down. And what you're saying to us is politicians making decisions about this need to take responsibility of the public and say it's about cost.
Yeah, absolutely. Mark MacDonald.
I guess the moment has kind of passed, but the point I wanted to address was that one could perhaps get the impression from the discussion that we're having that SMC is not approving any new medicines at all, and I don't think that's the case. And I just wonder, what is the kind of ratio of approval that is happening at SMC level, and maybe to get that onto the record, because the way the discussion has gone, one could be forgiven for assuming that there are no new medicines being approved by SMC.
Yes,
I think Professor Timoney has already given evidence to this committee, and would be best placed to answer that question for you. And also a point of information: my understanding is that there is a review of the IPTR process to start shortly, led by Professor Charles Swainson. So my understanding is that there is an appreciation of the fact that this process is not perfect and is subject to review to try and make it fit for purpose.
That's correct. I think I mentioned that review at the start of the committee, and that's why it was opportune, I think, that we got an opportunity to feed in some of the experience on the ground. And of course, there is a difference between the SMC approval and the individual patient treatment request situation as well. And I think while we have had some evidence about how successful that can be, we have also heard this morning that those figures, I think, may be underselling the problem, in that if you're screening out people, it's not an automatic process. Not everybody who seeks access to new medicines actually goes through that treatment. It's a minority of people who go through that treatment, and therefore a minority of people who are successful in that treatment. Yeah. So it's I think it is a deeper problem based on the evidence that we have. I'm just trying to go, Mark, Richard, and then I'll start bringing it to a close.
To clear up a point for myself and maybe other members of the committee, and the point that Dr. Stephen Harrow went on about the fact that he's not had access to certain drugs. How many people physically, and the question to him is, how many people actually physically do you need to do research into a new drug, or for those people to take the new drug, in order for Scotland to remain at the top of the league on cancer research, etc.? I think it doesn't need to be hundreds. It can be maybe, is it 5, 10, 20, 30? How many?
Is this so that we're perceived internationally and nationally as being able to offer patients the standard of care?
You made a comment that you have not, and I can't remember the two drugs you mentioned, that you haven't had access to these particular two drugs, which you felt wasn't allowing you to keep up your standard of care and also your research. So how many people would you need to have taken these drugs?
I think the majority of the patients who I was treated, I would have offered the standard of care that is now offered in Newcastle and Carlisle and across the border, which would be adding in biological agents along with the standard of care. That is the best care that they can have, and that is a lot of patients.
How many, roughly?
Well, I see 30 chemotherapy patients on a Wednesday afternoon clinic. So maybe half of them per week, and that's my practice, and there are other consultants.
So that's roughly 750 people a year.
Well, they're on a course, so it would be, not every week would be a new person getting that drug. They would be on a course. Okay. But again, it's the experience. I mean, I have no experience of using these drugs. I haven't, I didn't train with them. I had experience when I did my fellowship in Canada, but when I came back here, what was standard of care there was not standard of care, and that was in 2008. So this isn't a new problem.
Dr. Dunlop.
A couple of points to make. One is that the impression I think that you might leave here with is that in every strategic health authority south of the border, these drugs are available. That's not true. There are some strategic health authorities who've made the decision that drug X or drug Y is not on their list of drugs that is funded by the Cancer Drugs Fund. Secondly, we've heard the phrase standard of care in the developed world a lot at this meeting. Standard of care in the developed world is partly driven by reimbursement, Reimbursement determines the standard of care in many, many countries that do not have a public health system. And that has to be appreciated by the committee.
I don't know what the percentage of health boards south of the border that are offering what I would consider a standard of care, but I don't think because they're not offering it that we shouldn't be offering it in Scotland. We think that's the best treatment. If we can afford it, I think that should be what we should be aspiring to.
Yes.
Back to a point that was made over there about only looking at one part of the equation. I think most of us around the table would accept that we lack capacity in radiotherapy in Scotland. And just to try and measure up between the two, treating 20 patients with ipilimumab would buy me a new linear accelerator. So 20 patients would get chemo. A LINAC will treat 40 patients a day for 10 years. So while we're focusing on the drug side today, there is an opportunity cost if we fund more in the way of drugs, and that cost potentially could be at our inability to optimise our capacity in radiotherapy.
I think most committee members get the wider point. We're looking at this issue today and as part of this inquiry, but we are looking at the health service. We've just finished some work on the health service budget, so we're pretty aware, I think, of some of the pressures and strains and the competition that goes in there for those finite resources. Dr. Petty.
Just picking up on several points that have been made, I think, again, coming back to the what is value for money, particularly within the wider health service provision. I think it's. I know you're taking evidence from patients and patients groups, and you have done, and you may be taking more evidence. I think it's really important that we determine what the patients with cancer believe is value for money. I think that is the key issue here, that we need to determine what cancer patients see as value for money, because difficult as it is to speak to patients about these issues face to face, it is possible to do it. Not in all cases, but because of the complexities of the clinical situation, but it is possible to do it, and we all do that in our clinical practice every day. And patients are, we should not underestimate the ability of patients with cancer to appreciate what is value for money and make trade-offs in terms of, linear accelerators versus drugs. So I think that I would say that we really need to ensure that as part of this process, or going forward, that we get some idea on what this is or how to determine this.
I think that's a nice view, because our next panel is going to look at the patient focus. At this point, you have an opportunity still at this point if there are issues here. I think we've covered quite a lot. But at this point, if there are any areas that you feel that haven't been covered and are not on the record that you would wish to put on the record at this point, then I give you an opportunity to do so now. If you feel that there's been an important point that hasn't been brought out by questions, we've also got your written evidence as well. But if you don't feel the need to do any of that at this point, then just remains for me to thank you all very, very much for your time this morning, your participation in the evidence that you provided in written form and orally here this morning. Thank you all very much for your attendance here today. Thank you. Thank you. Point where we turn round. Good. We've now been welcomed by our second panel on this evidence session, and I think what we'll do, as we did in the first, we'll go around the table and introduce ourselves, if that's okay, before we move to our discussion. David, will you?
David Torrance, MSP, Kirkcaldy constituency.
Eric Lowe, Chief Executive, Maluma UK. Mark MacDonald, MSP for North East Scotland.
Karen McNee, Communities Development, James Whale Fund, Scotland. Eileen MacLeod, MSP for South of Scotland.
Gil Patterson, MSP for Clydebank Mulgai.
Kate Seymour, External Affairs Manager from Macmillan Cancer Support.
Drew Smith, Member for Glasgow.
Alistair Haw from Prostate Cancer UK.
Annette Milne, MSP for North East Scotland.
Vicky Crichton, Public Affairs Manager for Cancer Research UK.
Richard Lyle, MSP for Central Region of Scotland.
Lee Smith from Melanoma Action and Support Scotland.
And Duncan McNeill, MSP for Greenock and Inverclyde and convener of the Health and Sport Committee. Welcome to you all. You may have been here for the earlier session, and I think we opened that up on basis on the SPICE briefing that we have about whether the current appraisal system is the SMC is fit for purpose generally for orphan medicines or high cost cancer medicines, and as I said earlier, we hope that you'll be able to discuss this among each other, and we'll give you precedence in bringing you in, and we'll do our best to do more listening than talking. I'm not always successful, but does anyone want to pick up the general question about the current system and where we feel that that's fit for purpose? Yes.
Obviously, as a representative of Prostate Cancer UK, one of the most recent and high-profile cases would be abiraterone, and a lot of our experience of the system is based on that. And the general feeling that we have about the SMC system is that it doesn't take sufficient interest of what the patients feel about a drug. In comparison to the system south of the border, NICE, it really isn't as open. It doesn't give individual patients the opportunity to feed into the process. It doesn't give people the opportunity to turn up and to give direct evidence on behalf of the charity or patient interest groups. The system in Scotland is that we can merely give written evidence to them, and the way that's dealt with is quite different and inadequate. Whereas with NICE, if there's something coming up that relates to you, you're proactively contacted, you're informed about it, you're given advance warning. Whereas in Scotland, it's a case of check their website and keep your eye out for it. So in that sense, the SMC doesn't seem as open as is the case south of the border, and that's something which we'd be very keen to develop and to improve upon. There is a very strong feeling, I think, amongst patients that there's the unfairness of this. And again, with reference to abiraterone, I think if we look at the way that was developed, the thing that added to that sense of injustice was the fact that in England and Wales it was approved prior to Scotland, and Northern Ireland was next in line. And throughout that entire process, when men in Scotland who were dying of incurable prostate cancer and a considerable degree of pain could see that the drug was widely available south of the border via the Cancer Drug Fund, so that added to the sense of injustice. And one other point that I'd like to make in relation to the Cancer Drugs Fund, though I'm not, and my charity would not argue for that to be implemented across the whole of the UK because we understand and accept it as a kind of short-term England-only solution. I think one of the other problems that arose throughout this entire process was that when patients were expressing disappointment about the inability to access abiraterone via the NHS, and that it was available widely in England, and we have figures which show that during that period 97% of people who applied for it via the Cancer Drug Fund got access to it. Quite often you would have government ministers and politicians pointing to the individual patient treatment request as some sort of Cancer Drug Fund with a kilt you can just apply for it and you'll be able to get it. And that's actually not how it worked at all. And that raised a lot of expectations falsely. And it led to individual patients going to their doctor requesting it. And they would even have anecdotal evidence of doctors saying, OK, I'll go through the motions and apply for this, but you're not going to get it. And so the whole system in Scotland just seems it needs to be more accessible to patients. It needs to give the impression that we're actually listening to patients and giving feedback on what information the charity provides to and patient interest groups provide to the drug approval process. So that would be my opening gambit.
Mr. Lowe.
So I think we need to be cautious about what we've heard this morning in terms of comparisons particularly. We're not comparing apples with apples. The NICE system is very different to the SMC system, and I'm not sure that making these constant comparisons between the two processes is necessarily giving MSPs the right message. I think what we've got to concentrate on is what is the problem in Scotland? Can we really define exactly what the problem is and what the reasons for that problem are? I don't know if anybody knows what NICE's budget is and how many staff they employ compared to what the SMC budget is and how many staff they employ. It's not a fair fight. The SMC employ 14 people. And I think given their workload and what they do a spectacular job. And I think that if we really want to help, we've got to sit down with SMC and understand what they need to do, the job they want to do. They simply can't do it. I mean, you've asked for all this patient input, and I think you're right. But SMC just simply do not have the remit or the process or the budget to get anywhere close to the level of patient involvement that NICE has. But you would need to have some evidence as to, well, what difference does patient involvement make? Because if you speak to NICE and ask them for the evidence, at what point in the appraisal process does patient input make a difference? What do you think they would say? No, I mean, they would say hardly ever does it make a difference. There's evidence that's coming from Canada that they have a very evolved HTA process based on a combination of SMC and NICE. And the evidence is the more patient involvement is, the more likely it is to be a negative outcome. And it's not that patients don't have a very, very important role to make, but it's about cost effectiveness. That's what it comes down to. And if the drug is not cost effective, there's a limit to what we can do as patient advocates to truly make a massive difference, unless it's on the margin of the quality. So we talked about thresholds this morning. The threshold in Scotland is exactly the same as in it's £30,000, not 40, not 50. In England, there's just been evidence published that they want to reduce the threshold, not increase it. And patient input only really makes a massive difference where we're on that threshold. Similarly, making the comparisons with kind of Europe is very, very difficult. And I think what we need to do is we need a thorough interrogation of Scotland, not the comparisons, but what are the issues and barriers in Scotland that are preventing or causing the problems that we have. The first thing is that the IPTR thing isn't fit for purpose. And if we get nothing out of this morning, we've got to can that. We've got to stop putting patients through that process. It is awful, absolutely awful. It's not fit for purpose. It never has been and never will be. The problem is, what do we do next? So we need to look at SMC and we need to think about, well, what are the reasons that SMC are saying no? That never came up this morning. It's not just about cost effectiveness. So we've asked the SMC, and others around the table have been there, and they say that often the reasons that they say no is because the submission from the drug company is not good enough. That the data that's being presented has a degree of uncertainty. So I think that what we need to concentrate on is we need to say, well, if the inputs into the system aren't great, what comes out of the system won't be great. But the problem is drug companies don't necessarily have the scope, and SMC don't have the process for early engagement like you can do in England with NICE. So for me, it's around, let's look at SMC. I think they do a fantastic job, but they need resourced. They need more resources and a more flexible, more pragmatic remit to engage with industry early on so they can understand ahead of time what the potential issues could be and have enough time then to work on finding solutions to make sure that the evidence and the data that SMC have upon which they're going to make these very, very difficult decisions is fit for purpose for Scotland, and it isn't currently. And then I agree with some of the comments that we had this morning, that in making these appraisal decisions, these decisions about what to say yes and no to, we do need a bit more transparency about the decision-making around the table. We do need to understand a bit more about how SMC apply their decision-modifying criteria. And possibly we need to give NICE a remit to have more of a direct discussion with industry about price. Because price is a big issue. We've heard that this morning. It is in England. I mean, part of the reason NICE are saying yes more often now is because they have the ability to discuss price. They can do a commercial and confidence discount. And all the drugs that are being approved at the moment in England come with a sizable discount. And that's why they're being approved. But the SMC doesn't have the same remit to have these types of discussions with industry. So I think it's not about having knee-jerk reactions. It's about being calm and sitting with SMC, sitting with industry, and looking to see how we can improve the system that we've got to deal with some of the issues that come out the other end.
I'll let you back in, but I'll take Vicky here at this point and just let you know. But I'll let that go. I'll let
just
it go.
In case, some of the points I might have made at the outset might have been misinterpreted. What I was saying about the SNC wasn't an attack on the staff of the SMC, and I completely accept your point that those who do work there are working extremely hard and to the very best of ability, given the resources that they have. However, I feel that some of your points that you made almost gave the impression of saying, well, because you felt that the patient voice didn't really have much of an impact. It's almost a case for saying, well, why bother consulting the patient? I don't know if I would agree with that. But I would also suggest that as a result of some of the contact we've had with the SMC, as a result of a letter in the Herald, which was from our Chief Executive Owen Sharp, there was an exchange of letters with ourselves and the SMC, and they made clear that there have been a number of instances where the input of patients have led to them making a different decision. So I don't think it's quite accurate to say that it doesn't make a difference. But at the same time, I think it's very important that patients, especially those in the case of abiraterone, where we're talking about men who are terminally ill, and are in many cases in extreme pain, can see that around the UK everyone else is able to have accepted abiraterone on their health service, and men in England were able to access it for months. They are not able to do so, and particularly when there's a very high profile example of an individual who was widely assumed to be on abiraterone that extended his life. That made it extremely difficult. And as that was happening, when they were really keen to get their voice heard, to make people in the SMC know how they felt about it and how much of an impact it would have on their life to have abiraterone, to be told they can't even, as an individual, make any representations to them is something which I feel really has to be addressed. They can make representations to, for example, ourselves or other cancer charities, and we can feed it in. But for individuals to have no voice at all, which is currently the case, is a position which I feel is completely untenable.
I'm anxious to get in. Vicky Crichton, yeah.
Thanks. I think the first thing that I would want to say is that SMC does a really important job in very difficult circumstances. I think we would probably all agree with that. What's important in terms of having a system that works is that it's evidence-based, that it's equitable, and that it's transparent. Evidence-based, I think it is at the moment, and there are certainly some improvements that could be made to the SMC system, and we can perhaps come back to those. Equitable, I think there are some real challenges around about decision-making at local level, and whether that's in fact the case, so almost post-SMC, both in terms of health boards implementing SMC guidance and then also the IPTR system. Where there are real issues is around about transparency as well, and that's something particularly important, both in terms of SMC being able to be perhaps more transparent about its decision-making processes, and then also transparency at local level. picking up on the discussion that's just been made about patient involvement, one of the massive strengths of SMC is the speed at which it undertakes its appraisals. It's incredibly quick, and that's very welcome from a patient perspective, that those decisions are made swiftly. The process that's been discussed that NICE undergoes in England is a much more deliberative process, and it does have much more input from patients, much more discussion with clinicians. Those things are incredibly welcome, but they come with a time burden. And perhaps what we need to look at is how we balance those two things against each other, so we can have some more input from patients and patient groups into the discussions, so that we make sure that clinicians feel that they have been sufficiently listened to throughout the SMC process, but that we do that in a way that doesn't significantly add additional time to SMC's decision-making processes, because that would be a loss.
Kate Seymour.
Yeah, I'd want to reiterate what's been said about the IPTR, in that it used to be called exceptional funding or exceptional prescribing, and it is about exceptional cases, and it is for individuals. We really need to focus down on where the SMC is not working at the moment. I'd agree that on the whole it does a very good job, but there are groups of patients, particularly those at end of life and some with rarer cancers, that the system doesn't work for at the moment. And we need to, I have great sympathy with this committee, that when I started working on this issue, it was like wading through treacle trying to understand how things worked and what it must be like for patients. I can only imagine, and I think to be able to focus down on where is the system not working at the moment, so that we can look at how that can be fixed, and whether you can have a perfect system or not remains to be seen, but we can certainly do better for some groups of patients, particularly those at end of life and with some rarer cancers. The transparency issue is hugely important. It might not change decisions, but for patients to be able to understand what's happening to them, why decisions are made, is really important. And I actually think it does have an impact on the outcomes of decisions, particularly something that was said this morning around the use of modifiers. In England, modifiers, very specifically about end of life, those didn't work perfectly either, I would say, but at least it was very clear that these were being aimed at end of life. And I think that if the SMC could be more transparent, not just the SMC, all the other bodies involved could be more transparent about how decisions are made and why decisions are made, even if it doesn't necessarily change those decisions, I think it would make it would change the system and in the way that it worked. I do agree that this is primarily about budgets. I know that we're talking about access to medicines, but there was stuff in the media earlier this week about issues with radiotherapy capacity and staffing. And if we are talking about cancer treatment, it has to be as a whole and as the budget as a whole, because obviously what we wouldn't want to see would be money taken from radiotherapy capacity, or, for instance, from palliative care. The cancer service is an expensive, very important service, and we need to look at it as a whole. And I think on the patient involvement issue, one thing I would say is that when we're looking at patient involvement, what we need to be careful of is that it would remain equitable, because I think for some groups, for instance, prostate cancer, there are good, strong charities and support groups supporting people. There are other people who may be the only person in Scotland or amongst a very small group in the UK with a particular cancer, and for them to advocate on their own behalf is much more difficult. So I think with any system we look to put in place, we always need to look at the weakest point of what that will be and how we can mitigate against that.
Smith?
I would take up the points about the size of the charity and the capacity to represent patients. We are a very small charity, but we're representing patients who have early disease as well as those with late disease. With the early disease, it's mainly we're trying to reassure them and give them the psychological support to live with going back to clinics on a regular basis. And for those at the other end who are attending the oncology units, we appreciate that things for them are exceedingly tough. And over the almost 10 years now that our group has been meeting, we have just seen so many young people die that we stopped having group meetings, and we offer support on a one-to-one basis, and we only have meetings where we have speakers talking about genetics or aromatherapy or things of that sort, because it just became too trying for people to watch young folk round about them going downhill and dying. And we even had more than one case where the patient has not come back in the early days to these meetings because they've had bad news and been told that, you know, there isn't anything else for you. And as you've already heard, so first of all, can I say that I am just so impressed, and I'm not crawling, I am just so impressed with the official report from the 18th of September. I really think our MSPs do an absolutely fantastic job in wading through this treacle and really getting a handle on it. And I really, you know, I'm so impressed. Secondly, I honestly don't think, I think the SMC are almost to be pitied. They are being pilloried, and it's not the first time I've cursed them too, but they do have an exceedingly difficult job. They do their best. They do have an alert system. If you register with them, they will email you when a drug in your area comes up. So they do try to help us. And also, they appointed the Public Involvement Officer, Linda McGlynn. Linda has been a tremendous help, particularly to people to us who are learning our way. And we get informal feedback, and Linda might be able to help you with that. And we know that where there is almost a 50-50 in the committee, what the patients have said can swing the difference. Now, unfortunately, we haven't been able to swing the difference. We've had 2 new drugs, the first since the 1970s, and these 2 new drugs have improved the chances of people surviving. And this is the most common cancer in the 15 to 34-year-old. It kills more people under retirement age than over it. And I, of course, am biased. I was one of the few people who responded to DTIC. I was treated in 1983, and I'm still alive and well today. And nobody would have given a fiver for my year survival, never mind 5-year survival. But I know 3 of us who've got through and come out the other end. And until patients get the chance to try a drug, we really don't know what the outcome will be, because statistics only give you guidance. The individual patient is not a statistic. And this is where the great heartbreak comes in. And I appreciate the SMC can't look at a family and say, this woman has an 18-month-old child, as I had. She has elderly parents. We can expect her to bring up her child at no cost to the state. We can expect her to be back at work being a taxpayer, which I still am, and was until I was 62, with a good salary, and I looked after my parents until they died. But that's not taken into the equation. And I just wonder if we need to be very, very strong and say that, up until you're 70, you can have these more expensive drugs. And once you get to 70, you've had your 3 score year and 10, and I'll be 70 on my next birthday. You know, we have to let young people have the money that we've got. Thank you.
Thank you. You got a wee bit extra there for those nice comments. You see that? So. But I would ask. We are under the restrictions of time, and I want people to get back in. Is there anyone else want to respond to the sort of general question? No. Because I don't know where we just want to open it up to, because I think we had in that session, you know, some positive points for the SMC about the swift action, the benefits of patient access. And I think from Mr. Lowe we had, leading us into this next question, some ideas about whether and how it could be improved in terms of raising issues like the threshold, the flexible remit, the discount, the quality, the cost issues. So I don't know whether we can go to some of that, but if you want in at this point, Mark.
If you're opening it up.
I was opening it up for our panellists. Go on.
I had some questions which have flowed on from what's been said so far, and it was interesting some of the stuff that Mr. Lowe was saying about some of the reasons behind medicines being rejected, and perhaps I wonder if there's perhaps an element of spin out there in terms of the focus being purely on the cost issue, whereas what we're hearing here is that sometimes the sort of the technical data, the clinical data that lies behind the submissions is the reason for rejection, and we're not maybe getting evidence to that effect or hearing enough to that effect. And I wonder if that's part of the transparency issue about whether SMC should perhaps be looking at how better they can report the reasons behind rejection of medicines, so that it doesn't just simply become the case that people perceive that every medicine that is rejected on the basis of cost. I mean, I'm a big fan of the bad science column that Ben Goldacre writes in The Guardian, where he often talks about the difficulties that are out there in terms of getting accurate reportage of things like clinical trials and things like the clinical data that lies behind medicines. And often we see reportage of, wonder drug, for example, on the basis of what might not be the most robust data that lies behind it, but the perception is then placed into the minds of the public. So I wonder if that's maybe something that we need to look at around the wider transparency agenda, and do we need to look at how better SMC report the reasons that lie behind the rejection of new medicines?
Coming on that, I think industry obviously has an incredibly important role to play in this, in terms of making sure that the submissions that it makes to SMC are both responsible in terms of the prices that they're offering, and also that the data and evidence that they're submitting is sufficient for SMC to be able to make a decision. I've become a bit of an expert in deciphering SMC decisions, and the language is incredibly opaque. Once you start to learn the codes, you can see when they're saying this is simply too expensive, and when they're saying the data isn't strong enough. But it's not in particularly accessible language. And actually, I think it would be incredibly helpful if SMC were able to be clearer and more direct about the reasons that they're saying no, because I think the perception often is that there can only be one reason, and that's not always the case.
Yes.
Sorry, I think these last two people that made points are kind of great points, and I think NICE have the same issue of this uncertainty of the data. And I think we had the discussions this morning, or you had the discussions this morning, about the complexity of the system from an American, European, NICE, SMC, IPTR kind of process, but they're all there to do different things. So, for example, the role of Europe, so the European Medicines Agency and the FDA in the States, is around safety and efficacy. They're not interested in price or value for money. It's not their job. So when drug companies do their global registration studies to bring a drug to market, they have some commercial decisions about what the trial design should look like. But the FDA and EMA have a big say in what that study should look like. So these are sort of miles away from Scotland and the SMC at that point. These are global studies that are done for safety and efficacy, influenced by whatever the commercial agenda is, which is perfectly legitimate to have, and the FDA and EMA. So when NICE and an SMC get the data, it doesn't fit neatly into their remit, which is to make good decisions around how we can spend a finite budget in Scotland or in the UK. And that's what they grapple with, is how valuable is this drug to Scotland based on the evidence that we have in front of them. And it's not sort of Ben Goldacre, the ABPI, EMIG, BIA, everybody understands there's huge limitations in the data that we're asking NICE and SMC to assess. And that's what I said earlier. If the inputs into the system are suboptimal, then what comes out the other end could be suboptimal. And I think the big challenge for us all is to think about how we can come together to make sure that the evidence on which we're basing these very, very difficult decisions is of a higher standard and is more relevant to the locality in which these investment decisions about how we spend our money are being made. And I think we struggle with that in Scotland and in the UK.
The SMC role is clearly based on a high cost for the cost factor.
Sure.
The quality works out.
Sure.
That is cost. So
absolutely. And when you introduce uncertainty into the quality, then the quality goes up. So even if you have a relatively cheap drug, the quality can be really high because of the uncertainty. And as Vicky said, it comes down to this relationship between the evidence and the cost of the drug. And these judgments are based on, they don't deem there to be enough evidence to warrant this amount of money for that amount of benefit.
But that doesn't apply to, we were different here. I mean, what was the difference between the prostate cancer drug being available in Northern Ireland and England, the rest of the UK and the rest of Europe and here? Why? It was cost.
It comes down to, I mean, and I'm obviously sympathetic to the abiraterone issue, and we said this morning that the vast majority of drugs get through, some fall foul of the system. We need to understand why and what we can do quickly to fix that. But the issue is that, as everybody knows, it came up this morning, price setting is a UK-wide responsibility, but making judgments about value is devolved. And I think that's sometimes where we get the discrepancy in access, where NICE have different criteria and a different remit to judge what they deem valuable versus Ireland and in Scotland. And actually, it is bizarre to some of us patient groups why we have 3 separate HTA systems in Scotland that quite often, in the UK, that throw up different and conflictual results.
But I suppose the challenge is we've got this review. How can it be made better? Is it worth a candle?
So some practical examples of things that could be done within the review. So a few people have mentioned end of life sort of modifiers or decision making. Most of the treatments that we're talking about that are available through the Cancer Drugs Fund in England and that are not available as standard on the NHS in Scotland are treatments for patients at end of life. They're treatments that offer additional quantity and quality of life for those patients. In terms of the SMC modifiers, they do have something that specifically says that if a treatment is for patients at end of life, that's taken into account and that there's more flexibility. It's not clear what the scope of that is. It's not particularly clear how much additional give that allows. And I think someone's referred to earlier that NICE has end of life criteria which are very clearly defined. This is how much additional give in the system for this in these categories. So that's one area where actually if SMC were to be advised that we believe that patients do particularly value treatments at that stage in life, and therefore we're going to give them a higher amount of flexibility, and this is how much you should allow. I think that would be one particularly helpful development.
Thanks. I mean, I think we are looking at, as a committee, some of these, how do you make it better, and if it can be made better. Mr. Hall, and then Lee Smith.
Yeah, I'd just like to go back to the point that was made by Mark MacDonald, and I would agree that that's actually a very important aspect of it. I know some from around the table have suggested they have perhaps had feedback on their submissions to the SMC, but from my experience of working on both abiraterone twice and also cabazitaxel, that wasn't the case for my organisation. But if improvements have been made there, I'm pleased to hear of that, and I look forward to that changing for us going forward. I think it's very important to be clearer about what the decisions are based upon, because I feel that, as Vicky has alluded to, sometimes it isn't as clear as it really ought to be. And if there was a bit more clarity provided, particularly about the input that's been made by a patient interest group such as ourselves, then that would help us to know how we could do things better in the future, to be better advocates on behalf of patients, and would also perhaps have a better understanding of the impact that the information that we provided to the SMC on behalf of patients, as on the back of a survey perhaps that we have undertaken, if that had had an impact, if it could have had more of an impact, that sort of thing. And I feel at present we're still a bit in the dark. And just very briefly on the patient involvement point, if that's possible, others have pointed out that it can be very difficult for patients to make direct representations, especially if it's a very rare cancer, there'll be very rare disease. That can be very difficult. But the other side of the coin is, of course, there are also some small charities or small patient interest groups that don't have the capacity to respond to these things. And with that being the case, there can be no input at all from the public, either directly or indirectly. And we've actually had the SMC acknowledge that they have, even in cases where they have directly sought advice from a patient interest group, they've had nothing. And if there was the possibility for individuals to respond, then that would have given the opportunity to have at least some feedback from patients directly, if not indirectly. I think that's an important point.
Lee Smith.
The public involvement officer who helps small charities, and maybe even large charities, put in the submission has been a great benefit. And I must admit that I worked in the NHS for the first half of my working life and the pharmaceutical industry for the second half of my working life. So it's not just my experience as a patient, but I cannot understand why we've got committees of the New Drugs Committee, which is about roughly a dozen people, and the Full Drugs SMC Committee, which is 19 people, meeting at regular intervals to assess medicines when we know that a big part of their remit is ensuring we get value for money. And we have got health economists. We've got health economists on the SMC. And I just feel that what we really need to do is direct the drug companies to the health economist, first of all with their submission, for scrutiny before it's put in, so that we don't spend the money on these meetings and the time of these people without putting forward a submission that's got a chance of succeeding. And that could be done with a one-to-one with the health economist, helping the company to put forward the best argument, to understand the qualities and what the limitations of it are. And there would be a cost saving there, and it would maybe get things done a lot faster. I appreciate the SMC do work quickly, but if the drug companies were made to pay for that guidance through Andrew Walker at Glasgow University, for instance, we would get much better submissions and we might get more access to drugs.
Yes, Kate Seymour.
I think Eric referred to earlier, to be able to build more negotiation into the system, so it's not a drug company putting a submission in, SMC saying no, drug companies resubmitting if they have more evidence. It's a very... there isn't enough negotiation and flexibility within the system about the way that it works. So that can just prolong it. It can put drug companies off resubmitting. And if we can increase the communication between the SMC and the drug companies and involve patients and other groups in that as well, it should increase better outcomes, because we should be able to look at what the blockage is. And, you know, there may be some drugs that are just too expensive. There are, you know, we do have a finite budget, and I think, you know, that is for people here to look at the health budget and the amount of money we want to put into cancer services. But within the budget that we have to look at whether we can do better as well. And part of that must come through having discussions between the different parties at an early stage.
Comes back to those resources, though, that were mentioned earlier. If they're doing all of that, do we sacrifice the good that was identified by Vicky Crichton, that you know, that we have a process here when it works is swift, and one of the merits in it. If we've heard that there's 14 people, is that right, Mr. Law? And then, you know, and we're looking for engagement, we're looking for, you know, prior meetings before the applications go in, and is it reasonably asking all of that?
We've also talked about where we think there may be too many layers, though. So have we got our resources? Yeah. We don't want to just talk about the MSC. Let's look at the whole system. I know there are parts of the system that could be refocused into providing better outcomes.
Mr. Lowe?
I mean, I think these are really key points. And I think if you think about the cost of 2 new high-cost cancer drugs in comparison to what it would cost to add 2 or 3 staff to the SMC, I mean, the return on investment you would get would be phenomenal to invest these resources. And if we fixed the individual patient treatment request and took the investment out of that area and reapplied the SMC, it would be money well spent. Just to pick up on the point about end of life, is that obviously it's a key area, and NICE didn't introduce end of life criteria because patients who had cancer at end of life would value the intervention, because of course most of them would. They felt it was what society wanted them to do, and I think this is an important part about how you as MSPs and organise the health budget. Is what is societal preference for how money is spent. So NICE responded to that and felt that society were telling them that they valued end of life, and therefore they made some allowances with the end of life criteria. What's quite interesting is though that the actual threshold, the end of life has been you had to live for at least 2 years and you had to get a benefit from the drug of at least 3 months. It's completely arbitrary. It's not based on any empirical evidence whatsoever. So I think when the SMC looked at that, they felt, well, is that really what we want to do? We don't really have strong evidence for what societal preference really is, and we've got no evidence as to what the threshold for end of life should be. And they deemed that their decision modifiers accounted for end of life, but we don't really know because we don't really understand what they do. But there's a whole body of evidence coming out at the moment about societal preference for health investment, and if you don't have it, you should try and get access to that evidence, because I think it's very enlightening as to what society values in terms of quality of life and length of life at end of life.
Right. Issues that were raised in the earlier session about decisions made at local level. I think one of the concerns that we would have is that we've talked a little bit about some of the issues with SMC, but actually the decisions that are made in terms of putting those drugs onto the local formularies really aren't very transparent. Now, we actually don't know whether there is variation in access to treatments across Scotland, because the data simply, it isn't possible to read that from the information that's available. It may or may not be the case, but certainly the perception at the moment is that, SMC makes a decision and it isn't always clear whether those drugs are available. The Scottish Government guidance says that local health boards have to make that drug or its equivalent available. It should be the case that if they are saying, well, we're making an equivalent available, that they specify that. I think the second point is around about IPTRs, and there's been a lot of discussion about whether we should have them at all. They do a very specific job for a very small number of patients, and for those individual patients they'll be very important. They are not an answer to population access to treatments. But if we are going to have them, then thinking about some of the comments made by the clinicians this morning, the guidelines they are given need to be clear and transparent. They need to know what information, what evidence they need to be presenting to make a case that says this patient should have access, and what parameters will be used to judge that. Because that's clearly not the case, and that doesn't suggest a system which is equitable. By definition, those are individual decisions. The outcome might not be the same, so a patient in one area might get the drug and a patient elsewhere might not, because those patients are clinically different, and that's fine as long as the decision making is equitable and the process that's been gone through is equitable.
Just to pick up on point there from Vicky, after abiraterone was approved by the SMC, we took the opportunity to write to each health board in Scotland to ask when the drug was available, if it was available, and we actually did get quite a number of varying responses. We got some boards that said it's available as of now. We got others that said we're waiting for a local meeting to take place to decide whether we're going to put it on, and we got others who didn't respond. So we did have quite a wide variation of responses to that. And that was just another thing. Obviously, the example I keep coming back to is abiraterone, because that's our recent experience, and it's for men who don't have time to waste. They don't have lots of time on their hands, and they've also already been put through a process where they've seen it available elsewhere in the UK. People have said the SMC system is quicker, and I think evidence would suggest that is generally the case, but with the exception of Aberatom, is a very clear example when it took longer, despite having very limited patient involvement. So having been put through that entire process, when it finally is approved, people think, well, great, I can now get access to abiraterone, but not necessarily so. Some boards are very quick. Others think, well, that's very good, the SMC has said that, but we need to decide what we think ourselves. And so, to use the cliche about postcode lottery, that would appear to be the follow-up to the decision about the drug being approved. So, the general perception that once it's approved by SMC, then very, very swiftly it will be available to people who require that drug, I don't think from our experience is the case.
Richard Lyle.
Could I ask Mr Lowe, you made your sort of comments earlier, you're on about NICE, but head of population, what's their budget, how many staff have they got compared to Scotland?
I think they're, it's been reduced, but it was something like 80 million is their budget. I think they've got about 300 or 400 staff.
Sorry, 300 or 400 staff?
Yeah.
Compared to 14 for SMC in Scotland?
Yeah.
Right, I come back to also your comment, you said that your IPTR is not fit for purpose and should be done away with. What would you put in place?
Well, for the purpose for which IPTR was invented, it should stay. It should not be used to arbitrate for drugs that fall foul of SMC. And I think it's not exactly clear what should be put in its place. I think what we've discussed today is that we need to improve the SMC process to get more approvals. I think that is the first thing we need to do is not to provide a solution to a problem that we're not sure if it exists. I think it's look at the SMC process, get the early engagement, as Kate very rightly said, look at how we can modify the SMC process and decision-making modifiers, allow them to negotiate a bit more with industry on price, and see what happens. I think inevitably there will be a cohort of drugs that are just deemed to be too expensive and not worth the money. We need to accept that. Even as a strong patient advocate, we kind of need to accept that. But part of the issue is that there's often a discrepancy between the data that the SMC use to make their decisions and what doctors want to do in clinical practice. So the data is based on a phase 3 randomized study of a self-selected group of patients that have matched some entry criteria. The study was designed probably 10 years ago. But I have sympathy with what some of the doctors said today. They're highly skilled doctors that need to make good clinical decisions about the patient that's sitting in front of them. And patients aren't all the same. Their cancer is not all the same. Even prostate cancer, melanoma, there's a lot of heterogeneity. And we've got to give doctors a bit of informed decision-making capability to make good clinical decisions for their patients. And both in England and Scotland, we don't do that because of the strictness and robustness of guidance that comes from NICE and SMC. And we know there's huge limitations in that. So maybe part of the solution is actually to create an infrastructure where we can give doctors a proportion of the decision-making ability to invest wisely on behalf of their patients alongside SMC guidance.
Dr. Stephen Harlow said that he saw, on average, by my counting, 750 patients a year only submitted 2 IPTRs. Do you believe that doctors should have a percentage or a number that they should be allowed to submit if it's based on Dr. Harlow saying they only submitted 2 out of 750 people? Should you not think that he should have got that, been granted those IPTRs?
Yeah, I mean, ultimately there may have to be a number because we have to budget for these decisions, but I think we can predict how many decisions might be made in any given sort of budget year. So I think we do need to give doctors a degree of flexibility in making investment decisions, but it needs to be done within a framework. And as David Dunlop said, we can't advocate, really enthusiastic doctors going, So there needs to be a framework in which we can allow some empowerment to doctors to make good clinical decisions alongside SMC or in addition to SMC guidance.
Kate Seymour.
IPTR is not the answer to this issue. It works for what it is supposed to be there for, which is for individuals who are different to the rest of their patient population. What we have an issue with are groups of patients, sometimes very small groups of patients, sometimes bigger groups of patients, whose drugs have been turned down by the SMC. So the IPTR isn't the process. I think we probably need a process within the SMC that deals with it. It might be something that looks at, the IPTR is individual patient treatment requests. Maybe we need something that looks at group, specific groups. And I think what Dr. Harris said about having specialists as part of that decision-making process is extremely important. And it is a great concern that people are being asked to make decisions when they don't understand the intricacies of the progression of a disease or what a medicine might do.
Should there be, a sort of wider criteria for the SMC? Because we've heard, in the past, I think, from our evidence from SMC that I think they conceded to us at that point that they're looking at a particular budget, and decisions that they make at that point can impact on other budgets, in the community or caring or whatever. And I think, there seemed to be in that evidence an issue that they could have a broader criteria. We've heard this morning that in terms of cancer services, that must concern you, generally, that they can't recruit. There's a wider issue here about the health economy and how we maintain a leading edge in Scotland, and access to these medicines and new drugs are not just for the patient benefit, however many of them, they are for the wider health of the services that we provide, the skills that we have as a country, and how we maintain a leading edge in that. Mr. Lowe?
Again, I sort of would urge some caution to the MSPs around this notion about inward investment and being linked to SMC decisions. This NICE get the same story, and we've done a lot of work working with MPs down south and BIS and all these sort of trade industry associations, and it's a very controversial area, the extent to which how a drug is priced in a country relates to inward investment, because there's two types of research. There's the science that's done in laboratories and universities and academic institutions, and then there's the clinical development, which is the clinical trials. And these are two very different levels of investment.
Mr. Lowe, you were there this morning. David Dunlop, clinical lead in Scottish Cancer Research Network, West of Scotland, and involvement in SMC. Dr. Russell Petty, clinical senior lecturer. I could go on. But 8 senior consultants in cancer that you've just contradicted there. None of them, when asked if they didn't agree with the remarks that were made round the table, said that they disagreed that this was having an impact.
Sure.
Why should the committee take your evidence today?
Yeah. So I think there's some. I have huge respect for these doctors, and I've met as many doctors that kind of disagree. But I think that there is some self-interest there because they're kind of doing the studies. But I think if you look at all the reasons that a government has to get inward investment, a negative decision by SMC is only one of them. There's a huge number of other factors that the drug companies consider when making investment decisions for R&D. So I'm not disagreeing that it's a has an impact, but I think we need to be proportionate and balanced and not get too carried away.
I accept a clarification. I was just admiring your bravery to go against all of these people who are clinicians and indeed involved in the SMC, as Dr. Dunlop is. So that's I think clarification. Drew Smith.
I suppose, and hopefully most people were here for the morning session, and I think there is a difference coming through in this panel around where we think the issues are, and I'm hearing what people are saying about do we have the technical data, is it the way that SMC is taking decisions, how can we improve it? I suppose I just want to go back to the basics of this, because I think, Mr. Lowe, you said that the objective would be to make those improvements in order that more drugs could be approved. But is that our objective? And if so, could we just look at why that is? Do we have a situation in Scotland where we feel that not enough drugs are getting through the system and therefore we have a problem which we need to deal with? Or don't we?
No, I mean, I think it's a very good point, and I think that, as David Dunlop said, we're not trying to advocate a yes to every single drug, but it's this issue of value and cost. That in the system, if we can get a better relationship to the perceived value of the drug to the cost we want to pay, you might get more yeses, as they do in England now. And I think that's the issue, because the issue is that the price of the drug and the magnitude of the benefit are not deemed to be equitable. So if we could have some discussion around cost that's proportionate to the potential benefit, then we might get more yeses.
Some of those drugs that have been turned down by SMC, which show some clinical benefit, and again, most of those will be in the end-of-life category, but show some clinical benefit when we know that is incredibly valuable to those patients, but are not being made available, whether that's on high cost or problems with data. I think there are some of those drugs that we would very much like to see being made available. What we need to do is look at what it is that's stopping SMC from saying yes to them, and seeing if we can go back into the system and improve that. I think, as Eric says, it's not about everything being available, but it is about where there are treatments that do add additional benefit, and we've seen a number of those coming in recent years, that it is possible for SMC to make those treatments available.
There's been a lot of discussion about the budgets and all the rest of it, and I just wonder if health boards make any count up the value of the drugs which are given freely for the treatment of patients when the patients are on trials. Trials are important, not just to expand knowledge, but they're also there they are being used to treat patients, and the drugs are given free, and often the comparator drug is given free by the drug companies. So within itself, not having access to trials is going to put up the budget for the health board, and I just wonder if that's ever taken into account. And also where you make investment in equipment, staff and all the rest of it, drug companies pay for the investigations that patients have, so therefore you get more value out of the investment that you've made. And again, I don't think this is taken into account, and I do feel for the doctors who are having to, on a daily basis, turn down otherwise fit patients with a cancer.
Yes, Kate Seymour.
It's a passive system at the moment, and maybe what we need to look at is how we can build into the system a more proactive approach to, I think someone said this morning about looking at how do we get this drug approved. Is it this issue? Is it an issue of data? Is it an issue of cost? And that may just come because of the lack of capacity within the SMC. But if we can work more proactively to look at how do we we look at solving some of the issues with particular drugs. And I would say I don't think this is a very big problem, but it's quite a focused problem on particular areas and on particular medicines and on particular patient groups. So if we could focus proactively on where these problems are coming up and identify them a lot of the time before the decisions come, it's quite clear which ones are going to struggle to get through, and take all the action we can to try and solve the problem before it comes to an SMC decision, rather than the passive waiting for the decision, then waiting for a resubmission. That may help us to at least we would then be able to say to patients that we've taken every possible action to try and get their drug approved within the finite budget that exists.
Yes, Mr. Law.
I think that's a really important point. So just to give kind of one example of what our organisation has done. So we've sat down with drug companies, SMC and NICE and the NHS and said, okay, we know the pipeline for myeloma because it's so clear very early on, because these clinical trial protocols are done 5 years ago. So what we've done is we've engaged with SMC, NICE and the drug company, and we've looked at the protocol and picked it apart at a very early stage. And we've predicted that in 5-6 years' time, these are the areas that will be problematic for NICE and SMC when they're making decisions, because it's not based on a Scottish or UK comparator. So what we've built is we've built a clinical trial network of 8 institutions across the UK to set up an academic study to run alongside that global commercial study to deliver UK and Scottish-centric data that we then put on the table to SMC and NICE to sort of plug the evidence gaps that leads to this uncertainty around the value of a drug. One of the issues that we have is we weren't able to hook in a Scottish centre to the clinical trial network. And it goes back to some of the issues that they were saying this morning, is because we don't have the resources, we don't have the clinicians in place to commit the time to monitor clinical trials. And we only touched on this briefly this morning, but I think we do need to look at how we can incentivise a talent pool in Scotland. We heard this morning that there's issues around recruitment. We've tried to help recruit doctors to positions in Scotland, but it's very difficult to attract the talent because, again, the research infrastructure, but it's also, believe it or not, around, and this is not my personal opinion, this is the feedback I'm getting from these people, around the merit award. So there's doctors in England that were trained in Scotland who went to further their career in England. They want to come back, but can't come back. They can't afford to come back because the salaries are not competitive. Now, I don't know the ins and outs of it, but there seems to be some issues around attracting and recruiting top doctors to Scotland.
Gil Patterson.
Another tact. I was wondering, the issue that was raised this morning about VBP, if anyone had any insight into that and how that would affect Scotland.
I'm not sure if this entirely qualifies as insight. I think what you heard this morning, I think, is probably the case for all of us as well. In principle, the idea of value-based pricing is incredibly welcome. It brings some other things into the discussions around about value that are important to patients, and that seems like a good proposal. The two challenges I think there are at the moment is that, in general, there isn't an awful lot of information about what it will look like in practice, and given that we're talking about something coming in 2014, that's starting to become quite concerning, and that's at a UK level. There just isn't an awful lot of information. We do want to see that coming forward. We do want to see engagement with patients and patient groups about what they value, so that that can be taken into account. So it's incredibly important that that happens, and happens fairly swiftly. I think the second thing is the specifics around about how that will operate in Scotland. Because medicines pricing is reserved, but decisions about availability on the NHS are devolved. At the moment, we have that two-stage process where the decision is about the price is made at UK level, and then SMC operates here. Value-based pricing seems to suggest that those two processes will happen concurrently, which obviously leaves the question open as to, well, what role does SMC have, if any, post-value-based pricing? What discussions would take place in Scotland about that sort of access? So I think it's incredibly important, and we have said to the Scottish Government, it's incredibly important that they are engaging with colleagues in the UK Department of Health, that they are feeding in their comments, that they are making suggestions about how this needs to operate so that it makes sense for the Scottish system, because if the decision comes out and it doesn't work, it'll be very difficult to change it afterwards. So really a plea that there has to be strong engagement in that.
Anybody else?
I think. Yeah. Anyone else want to know? I think
I've got another question. Then.
Yeah, but just on the parliamentary answer to that, I think I think on your concern, I think the Scottish Government and the Health Secretary have been corresponding several times on this issue, and officials are working closely and engaged in that issue anyway. So I mean, I think that's a reassurance there that they are completely involved in that process, aware of what's going on, and participating fully in that process. Sorry, Gil.
Yeah, it's in another line of questioning. It's the issue that I raised earlier on this morning, and that's in regard to the kind of overall budget and how we, as lay persons, how do we make our decisions? And of course, this inquiry is specific on the purchase of drugs, effectively. And I wondered what you felt about, about preventative spend and the prospect, if you like, if we make recommendations that we actually might cut the feet away from some other spending, and everybody here is involved with cancer patients in one way or another, same as this morning, and it could effectively take some money away from something that's happening at the early stages. So I wonder what your feeling on that regard is. This is the wisdom of Solomon that I'm asking you to comment on.
Mr. Lowe and then Leishman.
So I think that is the issue that we all grapple with. There's a finite amount of money, and if you spend it here, you kind of can't spend it there. And everybody will argue their own case as to whether or not it should be in prevention or imaging or drugs or kind of whatever. And I'm not sure there's enough evidence, empirical evidence, about what society feels we should be spending money on. But I think one of the major challenges is that, I guess, optimally what we want to do is we want to have a health system that gives everybody what they need in terms of the best possible treatment and care, as discussed between the doctor and the patient for whatever that intervention may be, at a cost that is fair. And if we think about the budget as being finite, we have to talk about disinvestment. And in Scotland, as it is in England, there's lots of things that we do currently that aren't efficient. There is money in the system that we need to have a process by which we can strategically disinvest in certain areas and reinvest that money in the critical areas. And this is a thing that I think all governments are going to have to grapple with, is how can you strategically and fairly disinvest to create more money under the curve, as it were, to invest in the really critical areas as defined by a new multi-stakeholder process in the future.
Sorry, Elizabeth, I was going
to... No, okay.
Right, okay, Vicky Crane.
I wanted to pick up on what Kate said earlier around this issue, which is that the discussion about access to medicines has been incredibly high profile and very emotive, and that's understandably so, because for those patients and their families involved in this, it's a horrendous and difficult process. But I think it is important to note that when we're talking about just cancer treatment, for example, there have been incredible advances in surgery. There have been some incredible new radiotherapy techniques, which can also be incredibly expensive. but are very effective and very cost effective. And it is important that that doesn't get lost in the wider debate, because actually those don't tend to appear in the media. You don't tend to get people talking about, you know, whether they got a particular new form of radiotherapy in the same way that they talk about individual drugs. And that's without even starting to talk about the importance of early diagnosis and the importance of spending on preventative activities. So while this is understandably a difficult and important debate, it's absolutely not the case that this should be seen as wanting to take funding away from elsewhere in the system, because those things are vitally important.
We've got a submission from ABPI, you know, on the prescription charges, and they point to the loss of exclusivity LOE, which will save the NHS in Scotland an estimated £316 million, because these are going mainstream, if you like. So has there been any discussions with yourselves and Cancer Charity about how that would be used and how that will be invested, you know, that type of saving?
Well, I guess one thing is we speak to the ABPI all the time about finding solutions, and I think as much as we can be, we think that being collaborative and everybody getting out of the system what they need is important. I think it's very difficult for us to interpret some of the figures that get kind of bandied about and what it actually means. I guess one of the issues in the past where there has been savings made, it's what happens to the saving. So the NHS in Scotland has budget silos. So if I have a diagnostic test that costs £50 versus the old one at £1, but I'm the laboratory guy, I'm not going to spend the money because I don't get the benefit of that money. Even if it means that I can save 3 people from going to dialysis at a cost of £300,000, I don't get that saving. So I think there's a bit of work to be done around identifying where the savings can be made and how best to reinvest these savings in the NHS to get maximum benefit for patients, I guess, and the taxpayers. So I think there's a job of work to be done to think about how we allocate and use the savings that can be made, and how we can maybe get budgets working together rather than independently, so these savings can be realised.
Just that specific on that prescribing budget, they say there's going to be a gain of £316 million to the health service. It's about where that, maybe that's a bigger question for the committee, about where those savings would go if nobody else has done that. I'm going to bring in Mark first, and then Nanette, do you want in? Lee, did you want in that?
Just, yes, please.
Yes? Go on.
Do you want to go now? The question was about prevention and how to balance budgets. Of all the cancers, the most common cancer by far in Scotland is skin cancer. Whether it's basal cell or squamous cell cancers, they all have to be treated. The other two, basal cell and squamous cell, will less often kill people, but they still cost money to treat. And all of these, the non-melanoma and the melanoma cancers, are caused by overexposure to sun in at least 80% of cases. And we have children under our control from nursery age right through to their 20s. And there is nothing which requires individual schools or education authorities to provide any sort of protection for children over the spring and summer months when the children are mostly in school. And I'm sad to see that children get sunburned on their school sports day. And CR UK brought out a lovely wee simple quote a few years ago. One instance of severe sunburn, alternate years, triples your rates of skin cancer. We have it within our power to prevent so much skin cancer that with so little spend, that it must be worth it.
Mark.
A little bit of time, convener, in that Gil Patterson's question essentially wrapped up most of what I was going to ask, so you can skip past me.
We are coming to that point now, and I offer the same opportunity to Nanette. Sorry, Annette? Of course, I'm
more,
sorry. No,
it's probably more a comment than a question, but I think the points that Mr. Lowe made about disinvestment and about kind of silo budgeting were very, very important points. I think maybe goes beyond this particular inquiry we're doing, but I think it's something that the health service is going to have to look at. It did come out, I think it was our evidence session with the SMC when they said the other procedures and processes within the NHS are not scrutinised to the degree that the drugs availability is. And I think that is something to flag up that really has to be looked at as we've gone to the NHS. The other thing was the IPTR. And I was actually a member of the Petitions Committee when the issue about cetuximab cropped up and the difficulties that the exceptional prescribing procedure gave to patients. And it was on the back of that, really, that the IPTR system was devised as something that was going to make life a little bit easier for these exceptional patients, you might say, who were trying to get access to treatment. It clearly hasn't worked the way it was intended. I would think there needs to be a lot more clarity to the public at large about exactly what the IPTR system means within health boards as well, to make sure it's applied uniformly across the country if it's going to be continue to be applied. And I think that's today's flagged up that very significantly, I think.
Do you wish to respond? Yes.
Just on the IPTRs, I think it's already been, the evidence has been given both orally and some of the written submissions about the way that that's been misrepresented. And I think that really has to kind of stop happening, and it gives people false hope. But in terms of the lack of clarity, I think there's also an issue in the fact that no statistics are currently compiled about the number that are submitted and the response rate, and also the number who patients who might ask for one to be submitted but told they're not going to get one submitted because their doctor might feel it's a waste of time and it's not an appropriate system for them. So I think if there was some step made to start to collate these statistics throughout the country, it would build up a bigger picture. I think it's very important, given the context of the way it has been built up as a solution for people who need drugs that haven't yet been assessed by the SMC or that have been rejected by the SMC. I think that's a point I'd like on the record.
Okay, thank you. As I was about to say earlier, I mean, obviously we've tried to cover a number of areas. We have your written evidence, but obviously if there's a pressing issue that you feel hasn't been covered, that you would want to place on the record, then please do it now. Vicky Crichton.
Just something quickly about the review that's recently been announced. I think it's very welcome for obvious reasons that we're continuing to grapple with this issue, and the points that have been laid out, the pieces of work that are going to be undertaken, I think will be incredibly useful in that regard. I think what we perhaps haven't seen yet is, and the committee may have this information or may wish to ask for it, is some further information about the broader scope of that review, about the timescales and about the sort of stakeholder input. It's good to hear that the evidence the committee's been taking will be fed into that. I think it's important that happens and that stakeholder input is taken on board, and that what we're trying to work towards as part of this review is a long-term sustainable solution that is evidence-based, equitable and transparent, because sort of tinkering around the edges isn't going to help.
Yes, I think that point is well made. I mentioned earlier, and I mentioned the committee members, that we have, as you suggested, pursuing the remit of the inquiry through the Minister and his officials, and we're going to speak to that further with the people who are setting up the agenda. But we've had verbal assurances that we will still have time to complete our inquiry and feed that in, and we hope that they will, at the very least, read that with interest and will inform their discussions. Alistair?
Just point off a couple of final. That would be great, thanks. With relation to value-based pricing, just to put it on the record that Prostate Cancer UK has recently published a document, Getting It Right for People with Cancer, which has been published jointly with a number of other cancer charities, including these round the table, and I'd be happy to pass that on to the committee if that would be of assistance. I could possibly summarise the whole document here now, but just to reassure you, it's not just in Scotland which we complain that the patient interest is being sidelined. I think one of the key points from that is that the debate that's currently going on based at Westminster about value-based pricing seems to be one between the government and the pharmaceuticals industry, with the patients having been shut out. So that'd be one takeaway point from that, but I'd be happy to share that. Also, I made reference earlier to the letters we sent to health boards about abiraterone after the SNC approved that, and I'd be happy to share those with the committee also, if that would be beneficial. And just a final point really about the context of our experience of abiraterone, and hopefully I've made my case quite plainly about that and how people felt about that. But I feel the context of that is incredibly important. Not only is prostate cancer the most common cancer in men and almost as common as breast cancer is in women, but by 2030 it will be the most common cancer overall. But despite this, we had that experience with abiraterone. We also have recently had, within the last year or so, Detect Cancer Early published, which made no reference to prostate cancer. And we also had the quality performance indicators for prostate cancer, which were published, which were pretty patchy and sporadic and incomplete, which didn't seem to take much account at all of the evidence that we submitted. So that would be the context, I feel, of all the comments that we've made in our written and hopefully our oral submissions.
Okay, thanks for that, and we look forward to your further submissions. Wiesman, for the last word, since you were so nice earlier.
I must remember that for future.
Yes.
Sign guidance, we hope for a new sign guidance or a review of the sign guidance 72 on melanoma. And I just cannot imagine that the sign committee will not decide that the new drugs have a place in preference to DTIC, or secondly, at least second after DTIC. And I just wonder where that will place us. If signs say this should be the standard of treatment and the drugs have not been approved in the SMC, I honestly don't know where that puts us.
Okay, you've took the opportunity to place that on the record, and it will be part of our considerations. Can I thank you all very much for your attendance, your participation, and your help to the committee and your evidence. Thank you very much indeed. Thank you. Suspend.